Good morning, or good afternoon, or good evening. Welcome back to our second day of the Allied Professionals Forum and our third and final session of this year, this virtual conference. I hope you've enjoyed the program as much as Rachel and I have. We were talking a little offline, and there's so many things that we're just thrilled with the program so far, whether it's a confirmation of something that we're doing and we're doing it well or right, or it's something that we can use right now and add to our program, or it's something that we can aspire to look forward to trying in the future. So to start off this morning, we do have another sponsor. It's Mitsubishi Tanabe Pharma, and we're going to play a short video for you.
Health is precious, and disease can be a deadly adversary. Some diseases present us with seemingly impossible challenges, but we don't believe in impossible. We believe there is always a way to help people struggling with rare and debilitating diseases. Yes, it takes intelligence and courage. And yes, there may be disappointments and failures along the way. But we'll never stop pursuing the impossible. Because we know that one scientific breakthrough can change everything.
We are Mitsubishi Tanabe Pharma America, and we're in pursuit of the impossible.
Thank you for that, and thank you for your support. To start this last day of presentations, we're going to hear from Jane Lester and David Derry on a service development project to establish a joint respiratory motor neuron disease clinic.
Hello everybody, my name's Jane Lester. I work with the Motor Neuron Disease Care Centre in the Salford Care Organisation. I've got a post that's funded by the Motor Neuron Disease Association to work with the teams to develop the pathways and to support the best care that we can for people with MND.
I'm Dave Derry. I'm lead physiotherapist for the Northwest Ventilation Service over at Wythenshawe Hospital. I'll talk to you a little bit later about what our service is, but I'll hand you back over to Jane now.
So I want to talk to you about the project that we had to establish a joint respiratory and neurology motor neuron disease clinic. First of all, I'd just like to give a little bit of background. So Greater Manchester is a conurbation in the northwest of England. It consists of 10 boroughs, each with their own health service and health commissioning groups. There's a population overall of 2.8 million and a prevalence of MND where we have about 220 people living with MND at any one time, with about 100 new cases per year. So the Greater Manchester Care Centre for MND supports all people from the point of diagnosis and through the whole journey, providing medical and emotional support at all stages. There are three specialist neurologists and either 2 or 3 specialist nurses at any one time. And we also have specialist allied health professionals as part of the team, so including speech therapy, dietetics, physio, OT, psychologists and social worker. And we're supported by the palliative care services. So as I've said, the respiratory service is actually provided to different trusts, which Dave will explain later. There's also, we have day-to-day management of people's care through the community teams in each of the boroughs as well. So as you can see, the care can be quite complex. So back in 2016, the respiratory pathway was that all people with MND would attend the care centre at Salford Royal Hospital, where they'd have the breathing tests. If there was any evidence of respiratory compromise, then they'd be referred on to the Northwest Ventilation Service. And once seen there, they'd either commence with NIV or continue to be monitored by them. If someone had gotten into acute type 2 respiratory failure, they'd be admitted to Salford Royal to commence non-invasive ventilation and then transferred once stable to the Northwest ventilation unit to be set up with home NIV. So it's very much felt that there was a lot of duplication, and also that the pathway for people in acute respiratory failure really wasn't as good as it should be. So in 2017, an audit of services was carried out by an APEP student, Dan Rice-Wilson. And the audit compared the compliance with NICE guidelines for MND between January the 1st to December the 31st in 2016. 52 patients were referred to the Northwest Ventilation Service, of whom only 17 were started on NIV at the initial assessment, and 28 were deemed to have acceptable respiratory function and followed up by the ventilation team. Although the further 6 were started on NIV at subsequent appointments within that year. Unfortunately, 3 patients died before they were seen, and 1 patient refused follow-up after the initial consultation. There was no data on the outcome for the other 3 patients. Also, a total of 18 patients received a cough assist machine, 5 of whom started on NIV at the same time and 13 that didn't. So the audit demonstrated that there really was a duplication of appointments between the 2 appointments, or between the 2 organisations.
Thanks, Jane. So I'm just going to tell you a little bit about the Northwest Ventilation Service. So we are a tertiary referral centre, who are based at Wythenshawe Hospital in Manchester. So Wythenshawe is one of 3 university teaching hospitals in Manchester, the other 2 being Salford Royal and Manchester Royal Infirmary. We're actually part of Manchester University NHS Foundation Trust, which is a separate NHS trust to Salford Royal. We care for around about 1,500 patients across the region. So we cover the whole of the Northwest region, so not just including Greater Manchester. The only areas we don't cover are the Merseyside, so the Liverpool region, and parts of Lancashire, which have separate services for ventilation. But we provide long-term non-invasive ventilation and tracheostomy ventilation, and also cough augmentation therapy. So that's typically mechanical insufflation, exsufflation devices, lung volume recruitment devices, but also other forms of secretion clearance interventions. We have a specialist team, so specialist MDT, based on, we have consultant positions, specialist nurses and specialist allied health professionals. And from a physiotherapy perspective, the specialist physiotherapists, we're responsible for providing, for setting patients up onto non-invasive ventilation, tracheostomy ventilation, as well as cough augmentation therapy. We have an inpatient unit and also provide outpatient facilities and community outreach facilities as well too. And our community outreach team reviews patients in their own home. That's run by our specialist nurses and specialist physios, and we actually help to prevent unnecessary hospital admissions. We also aim to optimise quality of life and provide symptomatic relief of patients at home, as well as supporting patients coming towards the end of their life, so with appropriate and specialist palliative care support. And we liaise whenever required with the palliative care teams across the region. So towards the end of 2017, we actually set up a monthly joint respiratory neurology clinic over at Salford Royal, and that was specifically for patients with motor neuron disease. At that clinic, a respiratory consultant, so Dr. Sabah Bakari, and myself, a specialist respiratory physiotherapist, we attended the clinic once a month to review patients who were at risk of, or were showing signs of respiratory failure. And initially that was with a consultant neurologist present, but subsequently it moved to having a specialist nurse present in those clinics. So actually we had a true MDT there with across both services as well too. Based upon the findings from that clinic of each patient, they would either be allowed to continue just to come into the joint clinic at Salford Royal in the M&D Care Centre, or alternatively they could be referred into the Northwest Ventilation Service, either to be set up onto NIV or cough augmentation therapy. What was really nice though from that clinic was instead of what happened previously, if patients were found to be in acute respiratory failure, we could arrange for direct admission onto the Northwest Ventilation Unit, and that happened very quickly. So often within the space of less than 24 hours, and I think the quickest turnaround we had was within sort of 2 hours of the patient being seen by ourselves. They were actually within our unit, getting ready to be set up onto ventilation. So we actually reviewed the clinic, the impact of the clinic between December 2017 and November 2018. And within that time frame, we actually had 47 clinic appointments. We actually saw 33 patients. So some of those patients obviously attended for multiple appointments there. From those 33 patients, 22 referrals were made into the Northwest Ventilation Service, and there were an additional 16 patients referred into the Northwest Ventilation Service from the standard neurology clinics as well too. So a total of 38 referrals within that 12-month period were made to the ventilation team. What we found was that there was actually a reduction in the number of referrals into the ventilation service, down from 52 the year before down to 38. So there was actually 14 less patients referred into the service. As James mentioned previously, in 2016, of the 52 patients who were referred, there was only 17 of those patients that were set up onto an IV. So quite a large number of patients were attending the clinic, not unnecessarily really, and they could have just been seen over at Salford Royal. And in the 12 months from December 2017, of the 38 patients who were referred over to us in the ventilation service, 21 were set up. So 55% of those patients were actually set up onto an IV. And a further 3 were commenced onto cough assist, but didn't require an IV at that point. So it's really demonstrated that actually we're only referring patients into the service when they need to be referred into the service. So what's really nice is we're avoiding those unnecessary visits and duplication of appointments at multiple hospitals, which is not good for patients. What's been really nice in terms of the benefits from the clinic is that we can actually triage referrals into the Northwest Ventilation Service much better. So as I mentioned earlier, for those patients that require urgent admission, we can admit directly into into the Northwest Ventilation team at Wythenshawe, as opposed to having to admit them acutely into Salford Royal. So it's much better for patient experience, and it also reduces the length of stay that they have to have in hospital. We can actually highlight when patients need to be reviewed earlier on in our clinics, or if they need to be reviewed, if they need to have an inpatient admission at Wythenshawe Hospital for an IV or cough augmentation setup. And we can actually ensure that patients are following the correct pathways. So whether that be for cough augmentation therapy, whether it be for an IV setup, or whether it be for PEG insertions. So over at Wythenshawe, patients who are either at risk of developing respiratory failure or are in confirmed respiratory failure, and if they require a PEG, we can actually support their ventilation during the PEG insertion. So from the specialist team's perspective, we would support the ventilation with an IV, whilst the gastroenterologist physically inserts the PEG tube. What's been really nice is, as I mentioned previously, we've avoided those unnecessary appointments in the ventilation team at Wythenshawe, so it's freed up our clinic capacity, but also importantly, it's meant that patients don't have those duplicate appointments. But at the same time, it's ensured that we're compliant with the National Institute for Clinical Excellence guidelines around MND, in that patients must be reviewed, who are in respiratory failure must be reviewed jointly by both a neurologist and a respiratory team. We can actually give patients a much more informed decision as to what happens with an IV. So we can allow them to make a much more informed decision, So we can actually educate them around what an IV is, what cough augmentation therapy is as well too, what tracheostomy ventilation involves. So if the patient chooses not to proceed or they decline an IV, that decision can be made within the joint clinic, where they have support not only from us, but also from the MND care team, who actually probably know the patients better at this point. And we can actually refer patients into palliative care if required at this point as well too. From a professional perspective, what's been really nice is that we've actually been able to work jointly. We've shared knowledge across both services, and we've developed skills, across both services. But particularly importantly, we've really developed the communication. As Jane mentioned previously, I think communication channels weren't as good as they should have been a few years ago, whereas we've really worked on this and our communication is much more seamless between the two different teams, which is not only a benefit to us as clinicians, but really importantly, it's to the benefit of patients and service users. What's also been nice is that we've actually been able to identify any social or physical issues or limitations which might impact upon the patient's ability to use ventilation or cough augmentation therapy. So, for example, whether patients need care packages instigating earlier on, or whether we need to liaise with our occupational therapy team in the North West Ventilation Service to try and arrange for appropriate adaptations or appropriate adaptation to patients, improving patients' ability to engage in activity much more readily. We can access those interventions much more readily than we did previously.
So we carried out a survey of staff to find out what their sort of impressions and perceptions of the service were. We asked them to use words to describe it, and you can see the word map that was produced here. Generally, the responses were very positive, and in comments that included that patients now have less duplicate appointments. They also have conversations at the right time with the right people, and that care for people with acute respiratory failure is now more efficient. It was also said that it directly impacted on patient flow. Patients can now be referred directly from the clinic into an appointment bed or cough clinic at Wythenshawe within a matter of days. Patients seemed to be grateful that they could be reviewed in one hospital as opposed to multiple hospital visits. And there was avoidance of unnecessary appointments at Wythenshawe for patients who may be where NIV was not appropriate or they'd chosen not to proceed with it. So in terms of next steps, we actually continued to audit the service throughout 2019. And in that period, that 12-month period, there were 40 appointments for 38 patients, and there were 24 referrals into the ventilation service. So of those referrals, though, 11 were for people who were in acute respiratory failure who needed urgent admission. And certainly at least 6 of those patients would have been admitted to Salford rather than being referred to the ventilation service. But in all cases, it was possible to refer them into the ventilation unit, resulting in a shorter stay and a better care pathway. Also, 7 patients weren't referred, which is important because they're patients that would have previously been referred, so we were avoiding inappropriate referrals. Finally, really looking at the impact of the COVID pandemic, the clinics had to stop for most of this year. So we've actually set up a remote MDT meeting where we have the opportunity to discuss all the patients to address some of the difficulties that the pandemic has presented. But this is something we would have liked to have done a long time ago, but we didn't have the mechanisms to do it. And because we were on 2 different sites, it was very difficult to organise. But now with the rise of virtual technologies, this has now proved much easier to do, and is something that we're really keen to continue with. So going forwards now, we want to continue with the virtual MDT and having the joint face-to-face clinics. We think that this has really made a difference to the care and the providing seamless care for people as they go into who require respiratory support. So thank you for listening, everybody. Dave and I are happy to answer any questions, and we've added our emails here if you want to write and ask us anything.
Thank you, everyone.
Sarah, you're on mute.
I know, I got it. The unmute, dear Lord. Thank you very, very much. It's great to hear that you had less referrals, but more appropriate referrals. That just seems like that's the key takeaway that I was getting from that. This is open for questions. If anyone has any questions, I would like to, I was thinking about it just from a different perspective, like from our perspective, do you routinely see, if you're a respiratory physical therapist, do you routinely see them in the clinic, in the multidisciplinary clinic, or only when you're called in?
We routinely have a monthly clinic. So as a respiratory physiotherapist, we do go in for that monthly clinic jointly with our consultant physician.
And is that part of the MND clinic?
So it runs kind of hand in hand with the MND service clinic, and Jane obviously can speak a little bit more detail about the MND service at Salford. But we had it's kind of a joint sort of clinic which was set up between the respiratory team, which is from my service at Wythenshawe, and then the MND service based at Salford.
Hello. Yeah, I think at Salford, the MND service, everybody who comes and has their appointments would always have breathing tests done. So right from the point of diagnosis, they would have breathing tests done. At the point where there's evidence that they have got some degree of respiratory failure, that was when they would be referred through to the services at Wythenshawe into the direct respiratory services. And I think what was happening prior to this joint clinic being set up is that people were being referred sooner because we needed to be more cautious. But now that we've actually got the means to work together, we can make sure that those referrals are going through at the right time now. So people are regularly reviewed, but it's mainly for the breathing tests.
And there are some questions coming up. Rod Harris wants to know, are you receiving referrals late due to people being diagnosed later?
I think at the moment, sort of during the COVID pandemic, we know that there's been some delay in sort of the numbers of patients coming through. I think generally no, though. I think under normal circumstances, for the most part, people are coming through when we would expect. We do get some surprise patients who come through and we see them for the first time and we discover they're actually already in respiratory failure. So we do get some patients like that. And they're the ones now that we can immediately, we can get that sort of connection in with the ventilation unit and refer straight through to there, rather than referring into the hospital where the care centre's based, which then means that the patients have a more roundabout journey.
Right. So that even though it's later for them, it ends up being a shorter time.
Yeah.
Yeah. And then there's some specific question from Rachel Thompson about how did you get the go-ahead to start the clinic? You know, is it an informal arrangement or is it business case development?
I think initially when we proposed starting it, it was quite informally. So there were no kind of formal ties between the two organisations. So we kind of took it off our own back to try and initiate this. And it did take a little bit of persuading, to certainly with our organisation's senior management, about the benefits of it. But once we were able to pull some of the audit data through and actually demonstrate to them, they kind of saw what the benefits were, and actually, particularly in terms of releasing clinic slots for our patients at Wythenshawe as well too, they definitely found that was beneficial. So it is much more formalised now, but it did take a period of time for that to happen.
Yes, you showed them the deliverables. Is this something then that you think other places throughout the country will be able to implement?
I mean, I think from in the UK, some services, the ventilation services and neurology services in a lot of hospitals are actually within the same organisation. It just happens that in Manchester, unfortunately, the two organisations that provide long-term ventilation and neurology are in separate organisations, whereas most places they do tend to be a little bit more joined up, or there are services across the country that are slightly differently. I'll pass you on to Jane in terms of the other neurology services, as to whether or not she knows of any difference there.
Yeah, I'd agree with Dave that I think it depends on the setup, but I think we had a particularly complicated setup in Manchester But I think there are probably other areas that are similar within the UK, because we have the 10 boroughs, which each have their own community therapy services. Then we have the ventilation services in one organisation, the neurology services in another organisation, and it really made the situation very complex in terms of communication and coordination of care. So I think going forwards as well, now one of the other benefits that we're hoping to see it now is that the community teams, so it's those 10 separate community teams that support people with MND, will be able to communicate more directly in with the ventilation services as well, because their lines of communication have always tended to be with the care centre. So, but now with this, as this development's going forwards, now the community services have also got more direct lines of communication into the ventilation services, which I think really it's the whole thing then supports the patient pathway and makes it much more coordinated, seamless care than we would say we had previously.
That's excellent. Great work for both of you. That's going to conclude this one. If there are some other questions in the chat, if you want to take a look at them later. But thank you so much. It's excellent work that you're doing. So,
thank you.
The audience is clapping. We are now going to move on to the next presentation, which is Jenny Rolfe on exploring the effects of wheelchair prescription for holistic living in people living with MND.
Hello, my name is Jenny Rolfe. I'm an occupational therapist based in the Oxford MND Care Centre in the UK, and thank you for giving me the opportunity to present my case study to you today. So this case study, I'm going to give you an overview of the current situation. My presentation is concentrating on the wheelchair provision for this client and the issues that he's been having with his current provision, and what we are aiming to do with a different type of wheelchair that isn't normally standard provided by the NHS in England. So we're going to look at his needs and how we're going to meet them, and then what equipment we provided and how we measured how successful that was. So the case study is a gentleman who has spinal onset MND. He has been diagnosed for 3 years by the time we had got involved with a different power chair. By this time he is transferring using a hoist, and he has been using a powered wheelchair provided by the NHS for approximately 18 months. The chair that was provided by them was a Salsa Mini with some tilt-in space provided through Sunrise Medical, and this chair is funded through the NHS, and this is based on criteria that is set out by statutory funders. So the client presented to me in clinic and was reporting that he was uncomfortable in his wheelchair, and that he was experiencing quite a lot of pain when he was sitting in the chair for a long time. He particularly noted his legs would swell, and he had requested elevating powered leg rests on his power chair through his NHS provider, but the criteria under which the chairs are funded would not include this feature on the chair, so they were unable to provide this, even though the chair had the capacity to have that functionality. As a result, he was unable to sit in the chair for any length of time, and so he was really considering his role at work, whether he could continue to work, and also it was affecting how long he could travel for in a vehicle, because he couldn't sit in his chair for very long. So that limited his ability to go away, which he liked to do at the weekends, and also to travel to clinic, for example. So following seeing him in clinic, I completed a postural assessment, and Permobil is the company that's been partnering me in this project, and they have provided the power chair for this project. So a representative from Permobil attended the appointment with me, and we identified all of his seating needs and set out a prescription of chair to meet all his clinical as well as his social needs, which is not something that is normally looked at through NHS provision in great detail. The main emphasis is on clinical need. So the patient had aims of being comfortable, and he wanted to be able to travel in the chair for longer distances, continue to go to work, and he wanted to be able to take the power chair off-road slightly to go and walk the dog. He wasn't wanting to do major off-roading, but just to be able to go on a slightly bumpy track rather than a clean pavement to walk his dog. So to look at the provision of chair and how it differed between this chair compared to his NHS chair, we looked at what outcome measures we could use, and we used them at different time periods throughout the project. So I completed an interview with the client at the point of first assessment when he was finding problems with his chair, and then when we provided the Permobil chair, and then at 3 months, 6 months and 9 monthly intervals. The reason we wanted to do it over a long period of time was that we wanted to see if the Permobil continued to meet all of both his clinical and social needs over time. So we compared the NHS chair to the Permobil chair and looked at the Permobil over time. The outcome measures we used were the functioning every day in a wheelchair and the wheelchair outcome measure. And as I mentioned, a structured interview, which I completed with the person with MND and also his carer. So this table just sets out what I assessed for at different points in time. So you can see the Permobil, we had a baseline, looked at the functional activities, a carer baseline, 3 months, 6 months and 9 months, whereas the NHS chair was just in the baseline, because he stopped using the NHS chair once we provided the Permobil. The differences between the chairs were the NHS chair had a 30 degree of tilt and space, whereas the Permobil has 50 degrees. It had 30 degrees of powered recline, whereas the Permobil has 180 degrees of powered recline. It was a single actuator operation, so you could only move the tilt singly and then the recline, so you couldn't do them both at the same time. It had no memory settings, and as mentioned before, didn't have the powered elevating leg rests or a riser. The Permobil could move all the tilt and recline and elevate legs in one single motion, and it has memory settings, so you could set the chair up to go into office mode or going into vehicle mode, and you can just click on that memory setting and the chair will move into that position. So when we asked the client about how he was functioning in his NHS chair, these are the outcomes. He reported that his lifestyle and functional needs were limited due to his pain and discomfort, and he could only work a short amount of time, and he needed to rise up in the chair because he couldn't reach shelving. He reported pain in his bottom and his back, and his foot fell off the foot plate and needed frequent repositioning in the chair. He was able to drive the chair and using the controls without any problems, and the chair could get around his property, no problem at all. It could get inside his wheelchair accessible vehicle. However, he found it was not great going off-road, off pavements, so it was difficult walking the dog. He wasn't able to use any additional features like charging his phone or connect it to his phone. And the carer outcomes reported that there wasn't really any issues that she had, only that the client needed to be repositioned in the chair quite frequently. So asking the same questions of the Permobil after he had the chair, this is a baseline, so after the chair had been used for a week. And he reported that he was able to complete all his functions that he wanted to do at home and at work. He could sit in the chair for a much longer period of time, which meant he could travel and go to football matches. He can lay down in the chair at work to get a rest. In terms of his posture and comfort, he said that the back pain and bottom pain was relieved, and he was able to sit in all day and offload the amount of weight going through his buttocks due to the amount of tilt. He could change position in his chair, and so he didn't need to change into other alternative seating, and his edema, he reported, had improved in his legs. He had no problem with the controls. There was a slight issue with environment because this chair was slightly larger. He said it was more difficult to manoeuvre in the home, but he could do it, and it was slightly more difficult to get into his wheelchair accessible vehicle, but he was able to do this. He was able to connect his phone and charge his phone through the chair. The carer reported no problems with using the chair, and actually that she felt she needed to give her husband less support because he was transferring less into different other seating, and he needed less repositioning. So this table shows the functioning every day in a wheelchair results through the NHS chair and the Permobil chair. So this is comparing the NHS to the Permobil, and generally for each item on the functioning in everyday wheelchair, he had improved in the Permobil compared to the NHS chair. And then looking at how the Permobil fared over a time period from week 1, 3 months, 9 months, it continued to meet his needs, and he was able to demonstrate that throughout time the chair improved his functionality. So what does that mean to us as clinicians and in practice? Certainly in the UK there is a bit of a postcode lottery. Depending on where you live in the country will depend on what criteria your wheelchairs are commissioned under. So in some areas something like the riser for the legs, for example, may have been provided, but in the area that this gentleman was living in, it wasn't. The current criteria does only take into account clinical needs and basic environmental needs, and it also limits what equipment the NHS can provide. So the chairs and the technology available through the products that they're actually using is greater than what they are accessing. So it doesn't really maximise the potential for the product use or for the client use of that product. If we were to be a bit wider in our remit and look at funding chairs to improve not only clinical needs, clinical outcomes, but also looking at those functional outcomes, we could see a greater involvement of that person in different occupations and participation in different activities and society. There is the wider implications that actually if we can better support somebody in seating, they may well have less secondary health conditions. So for example, the edema in this client was reduced when he was able to elevate his legs and move his legs in an ergonomic way and use those memory settings on the Permobil. He reported that he could exercise his legs in the chair, which improved the edema and reduced the pain he was experiencing. We've also seen a reduced burden on the carer, so it may be that the prescribing a higher functioning chair could lower the care costs, where if somebody needs less repositioning and can do more tasks themselves in the chair, and the functionality is improved, that this could reduce the amount of care somebody needs. And generally, if somebody is able to participate in society and function in work roles, there is a contribution back into the economy of society, and this in itself will help the general sort of funding scheme of things. So that brings me to the end of this presentation. I'd just like to thank my client and his wife for taking part, also the MND Association who fund my time, and of course Permabil who provided the wheelchair and all the accessories that we used, and a member of staff from the company to assist me with setting the chair up. So I'd like to say thank you again for the opportunity, and if you have any questions, there's a live question and answer session that you can post your questions to. Thank you.
Thank you so much. There are a few questions. That was excellent. It's really interesting to see the difference. There is a question from Amber Ward from the US about, that this isn't necessarily specific to Permobil. I think you addressed it a little bit in your presentation, but if you could just address the differences in availability of power wheelchairs.
Yes, so in the UK, in England, the wheelchairs are prescribed under the NHS, so the person doesn't have to pay for the chair themselves, they don't have to buy it. So that's obviously a big cost saving to the person. However, everybody in the United Kingdom is entitled to a chair, so it has mobility issues, which limits how much money can be spent on individuals, and so there has to be quite a clear criteria as to who is eligible for certain products and what products are provided. Now, this differs around the country because commissioning for each area of the country is done by different groups, and so some areas will prioritise something like the elevating leg rests, whereas in other areas they don't. The point I was kind of making with the chairs are that actually the one that he was given by the NHS does have the capacity to have a lot of the features that the Permobil does. It's just that it wasn't funded to be put on. There could be the option for the client to increase the spending themselves, and certainly the MND Association spends a lot of money through their grants to provide top-ups for the power chairs, to provide functionalities such as the risers or an attendant control, for example, that aren't standardly provided in the NHS. The main difference in different manufacturers as well in the NHS, they are limited to a few manufacturers of products as opposed to the whole range that's clearly available. And so Permobil wouldn't be one that's typically provided through the NHS. And certainly the top end of some of the other products that are used in the NHS through Invacare and Sunrise, the higher end products are not generally prescribed that can do a lot of the functionality that I explained in the Permobil. So hopefully that covers that.
Yes. Which Permobil did he get?
The M3.
So that, yes. So somebody is asking about public transportation. Is it accessible to people using power wheelchairs?
Generally, yes. So buses and things like that can lower down. The rail service is a bit more haphazard, and certainly, for example, the tubes, because when they were built and designed, they were underground with lots of steps and no lifts. So there is an environmental issue for some wheelchair stations, but the rail network does try to make it as accessible as possible. And you can get wheelchair accessible taxis, but trying to get hold of one of those is quite difficult sometimes. It's easier in place in the cities, but in more rural areas, quite often a taxi will charge you to actually come out to your property and then take you. So you're paying 2 fees.
Okay, and I think we have time for one more question. And Pablo Aquino wants to know how do you help someone who can't get a Permobil through the NHS to get one?
The NHS used to run a scheme called the voucher scheme, and has now kind of rebranded it into something called the personal wheelchair budget. And this is where an individual can access some funding through the NHS to then take out and pay for their own chair. The difficulty with that is that the NHS buys a large number of chairs, so the cost that they're buying their chairs at, that is very different to a private dealer sale. So the money that you will get out from the NHS under one of these schemes is a drop in the ocean compared to the dealer private cost of the chair. So it is very difficult. The other issue, and we really encourage people to go through the NHS as much as possible, is that they will, as their needs change, the NHS will be monitoring their changing needs and can change the product to meet those changing needs. Whereas if you buy a chair from a private company, you're responsible entirely for any other adaptations that the chair needs to meet your changing needs. So any different controls and things like that, which can be hugely expensive.
I think that sounds like a problem around the globe. So I think maybe Jenny, you, I, and Amber, and anyone else who's interested, maybe we can do a study on this globe, worldwide.
That would be great.
So thank you very much. We're going to move on. Of course, Jenny, if you would also reply to some of the questions that are coming into the chat box, we would appreciate that. Thank you. We are moving on now to Christina Federico, who's going to talk about nutrition.
Hello, my name is Christina Federico. I'm a dietitian based at the Manchester Motor Neurone Disease Care Centre, which is situated in the northwest of England. And today I'm going to share some results and findings from a piece of work conducted in response to the COVID-19 pandemic, specifically around the nutritional management of our patients through the use of a multidisciplinary team meeting, which was nutrition focused. And so to acknowledge firstly my team members and colleagues who were heavily involved with this work, so in particular my speech and language therapy and specialist nursing colleagues, other members of our care centre and local services. So a small bit of background, Greater Manchester is defined as a metropolitan county in the northwest of England. And even prior to the COVID pandemic, it was really important with regards to nutritional management of our patients that there was clear communication and good coordination of care. And this is predominantly due to our services being split over different localities. So as a brief overview, we have the Neurosciences Centre where we are based, which is in Salford. The regional long-term ventilation services at a neighbouring hospital. And then dependent on patient need, they would be in contact with various members of community teams, local palliative care teams, and if they required an admission to their local hospital, there would be members at the acute hospitals that would link in and support with nutritional care. As a region, we have had high incident rates of COVID-19, and aside from the national lockdown, we've had periods of extended regional lockdown. I think this piece of work has allowed us to reflect and think back to the spring when a lot of this was unknown and there was uncertainty, and thinking about some of the pressures and challenges connected to the virus and how this has in particular impacted upon nutritional care of our patient group. So early on in the spring, the hospital site where our care centre is based and also where our ventilation service are based, both of those hospitals, their intensive care units became COVID intensive care units and had an increased number of intensive care beds. And due to that pressure and some of the uncertainty at that time, there were changes in the way that services operate. So we had the redeployment of some acute and community staff to support with that pressure, and that included team members that were usually heavily involved in the nutritional care of our motor neuron disease patients. Another pressure was the suspension of elective gastrostomy admissions and the gastrostomy pathway. And this change in a way of working that I think has been incredibly common, but thinking early on when it was a very new thing, the movement from face-to-face clinical review and assessment to virtual consultations and the downside that has, particularly around nutritional assessment. And then we have a vulnerable patient group, and this isn't just specific to nutrition, but it's something that is prevalent that has impacted upon nutritional care. So some of those consequences and challenges connected to shielding, so social isolation, psychological burden of shielding and how that impacts upon nutritional status. And then we do have areas of quite high deprivation in our region, and issues such as access to adequate nutrition could be an issue. And then more specifically to our patient group, some of the things mentioned, so the suspension of the elective gastrostomy pathway. Early on, there was a lot of anxiety and uncertainty around that, particularly for patients who had a date booked that was cancelled, or they were working towards a gastrostomy. And then obviously development of symptoms and the disease advancing. So patients where symptoms progress and it would impact upon their nutritional status, but the backdrop then of the concern about the virus and the changes to local services. And so these concerns led us to set up the nutrition focused MDT meeting. And I think we felt quite early on that because nutrition was a high area of concern, we wanted to have a forum where we could bring those concerns, have discussions and form appropriate action plans. And that has very much evolved as a piece of work. So we did meet weekly, it then was reduced to fortnightly, and it is currently monthly. And we have adopted a traffic light system, so red, amber, green, and the green now lower risk patients, some are just kept on the list, almost like as a surveillance and monitoring system. And so in terms of how the MDT would operate, in terms of identifying patients to be listed for discussion, that was predominantly led on by the specialist nurses. And action plans were always formed for the patients, and that could really vary dependent on patient needs and wouldn't be different, I think, to usual care in terms of bringing forward clinical reviews as needed and linking in with community teams. But perhaps because of the different ways of working and changes in services, there was a heavy emphasis on liaison between the care centre and local teams, so constantly referring back and checking where things were up to. And then a key component of the MDT forum has been around coordination of care with regards to tube feeding. And so for patients that weren't able to access the gastrostomy when those services were on hold, we were able to facilitate discussions around accessing shorter term tube feeding options such as nasogastric tube feeding. But I think upon reflection, the MDT forum allowed us to emphasise the concerns around the absence of the elective gastrostomy pathway, and it enabled us to progress forward and to develop a COVID-specific pathway that I know many centres now have. And also with our new way of working and using technology, we could link that in. So, for example, we are able to offer like a pre-gastrostomy admission contact with the patient, and we can do that over the video consult. In terms of data, we were keen to look at outcomes, both to assess the impact that COVID has had with regards to nutritional care, but also with this being a new piece of work, and to look at the nutrition outcomes. And at the time of submitting the abstract in August, we had 36 patients who had been discussed at the Nutrition MDT, but as is very common with our patient group, it was a very quick change in clinical picture for many patients. And we also have had a significant number of patients that have been added for discussion in the last few months. And so at the time of presenting in November, the updated data is that we have 57 patients who have been discussed at the Nutrition MDT, and for some of those patients on multiple occasions. Just to break down in a little bit more detail, 68% of those patients have bulbar symptoms, and just over half have respiratory involvement. We have a small number, so 12%, where there was absence of bulbar symptoms, but the respiratory issues were causing nutritional difficulties. And then another useful piece of data is that we had 11% of patients who had been diagnosed prior to the pandemic, but then presented with bulbar symptoms during the period of the pandemic, and that was a trigger that meant those patients were listed for discussion at the MDT. 42% of our patients were newly diagnosed during the pandemic, and of those new patients, so 24 in total, 75% had bulbar symptoms and a third had respiratory symptoms. A key role of the MDT was to form appropriate action plans and to link in with community services for ongoing support. And it was of interest that we had a higher number of patients that were under the care of local speech therapists compared to dietitians. But through discussion at the MDT, we were then able to facilitate referral for 44% of patients onwards to local dietetic services. In terms of nutritional risk, we obtained data about weight changes for the patients who were discussed in the MDT, and looking at percentage weight loss ranging from no loss to greater than 10%. This was weight changes that occurred from time of diagnosis to time of discussion at the MDT, and that ranged from 1 to 18 months. And so perhaps unsurprisingly, because it is a group of nutritionally compromised patients, we had 33% that had experienced greater than 10% weight loss. And then a point that's perhaps specific to this current way of working, and one of the negatives of the remote working, we have 19% of patients where we don't have accurate data around their weight changes. So we had some subjective feedback from patients about weight loss, but we didn't have definitive measurements to say the exact percentage weight change. As mentioned, the MDT forum was incredibly useful in facilitating discussions around tube feeding, and so looking specifically at gastrostomy outcomes with the gastrostomy services all now fully resumed. There were 47 patients in total where gastrostomy was indicated. It's quite a diverse picture in terms of outcomes, and perhaps a reflection of the quick changing clinical picture that can occur with our patients. So 34% now have a gastrostomy placed, and 17% are working towards, so in the process of having booked or have a date booked. 21% declined, and then the last two categories in terms of not suitable and missed is perhaps where there is some overlap. So those that were considered unsuitable had a fast deterioration in their disease, and so gastrostomy was perhaps identified early on, but then as things progressed, it was felt that it wasn't suitable due to advanced disease, or with some of our frontal temporal lobe dementia patients, through the best interest process, was felt not to be within their best interests. In terms of those that were considered to have missed, this is where COVID perhaps does have an impact, because we had a small number of patients who had been booked in for a gastrostomy prior to lockdown and changes in services. And for 3 of those patients, we considered nasogastric tube feeding either as a short-term or longer-term option if gastrostomy wasn't then available. They all declined that option. And then we did have a small number of patients, so 2 patients where gastrostomy had been discussed and worked towards prior to their MND diagnosis because of bulbar symptoms. They were then actually diagnosed, had a confirmed diagnosis of MND during inpatient admissions, and at that point had advanced disease. And so perhaps some overlap between the missed and unsuitable categories. Then looking at gastrostomy outcomes for our higher nutritional risk groups, so those that experience greater than 10% weight loss. Again, it varies, so some have now had PEGs placed, so 26% and 16% working towards, but then 26% considered not suitable. And again, with the missed category, they're patients that have had quite advanced disease or have frontal temporal lobe dementia, and some overlap again, and then 16% have declined. Because the nutrition-focused MDT has always been available since the spring, so always there for the newly diagnosed patients since the pandemic, thought it would be useful to look at the data for the patients that have been diagnosed during the pandemic to see about gastrostomy outcomes. And so for this group, 40% have now had a PEG placed and 20% are working towards. And as per the previous slides, we've got the mix of the declined and for the not suitable and missed, the patients that are in advanced stages of the disease. I think anecdotally for me, I feel there perhaps have been prompt actions around gastrostomy decisions, and I think some of that is due to the MDT forum, but also I think from patient consultation and feedback that COVID in itself has perhaps contributed to this, because patients have taken on board the advice around window of opportunity for gastrostomy and factored COVID into that. So I think there's a keenness to have gastrostomy done as soon as possible when fit and healthy, considering the virus as an additional risk and the uncertainty around kind of future hospital admissions and COVID being a risk factor. And then the final piece of data is around inpatient admissions. So as mentioned at the start, another component to nutritional care and teams that are involved in nutritional management of our patients is around inpatient admissions when patients perhaps go to their local hospitals. And so I thought it would be useful to look at the inpatient admissions that occurred for our patient group who were discussed in this MDT. And so in total, we had 28 admissions, and half of those were elective for the gastrostomy insertions once those services resumed. I think an interesting point for us were patients that were admitted as an emergency and were placed nil by mouth, so 3 in total. And this was a very common theme for reasons for patients to be discussed at our MDT to kind of provide that in-reach to the local hospital teams. And for those patients that were admitted and placed nil by mouth, they were people where there had been previous discussions about gastrostomy not being a suitable option, or they did not wish to have a gastrostomy, but then were in a situation where they were nil by mouth. And so through the work that we did as an MDT and linking in with the local teams, the decision was made for all 3 of those patients to risk feed orally. And so in terms of recommendations, I know that having nutrition-focused MDTs isn't a new thing, but I think doing this piece of work for us as a care centre has strengthened the argument for having that as part of our standard care as a centre. It also has highlighted to us the importance of having good communication and coordination around gastrostomy, and in particular having pre-gastrostomy admission clinics and also planning clinics when people are still in the decision-making process. And I think for both of those points about the future use of a nutrition MDT and a gastrostomy specific service, the new way of working and using virtual consultations has opened up, I think, opportunities to manage both of those services. And so rather than it just being done by the care centre staff, we can engage and link in with our local services. And also from a patient experience perspective, I think rather than having the same discussion with different members of different teams, it can help to bring that together, and so would be better for the patient. And then I think finally, in relation to the point made about the inpatient admissions where patients were placed nil by mouth, but there had been previous discussions in detail about tube feeding, and this wasn't something that was for them. Unfortunately, we do still have patients that don't make advanced directives with regards to artificial feeding. And so perhaps again with our new ways of working and virtual platforms and information sharing, there perhaps is a recommendation to look at how we enhance care to ensure that that information is clear and can be shared across the different teams. And so I think overall with all of the recommendations, the virtual way of working presents us with opportunities to look at improving patient care. And so thank you, and I'm happy to take any questions.
Thank you so much. We do have some questions. In your opinion, can a PEG be inserted too early and possibly lead to increased risk, or is it better to have it earlier?
Well, it's very individual, but I think prevention really is the key in terms of minimising the risk. So I do think with the evidence that's coming out about weight loss as an indicator, I think early placement is better, but it's having that detailed discussion about the care of the tube with the patient.
Yes. I mean, I think we always have to think individually with each person. And you made some very good points about how electronic and virtual now is really improving care as well. And I assume that moving forward with, even with COVID, maybe slowing down, you'll still continue to do that.
Definitely, yeah. And I think, obviously, I know that some colleagues from our care centre have presented previously about our clinics. And I think for our patient group, it's obviously really useful to have some face-to-face contact, but those sort of in-between contacts, so particularly when we're leading up to gastrostomy admission and planning, I found it being quite easy to have that video consultation with patient and their relatives, and we can kind of further plan for the admission. So I think definitely a combination would be the way forward.
Yes, Yeah, that sounds great. You guys are doing great work, and I'm going to let you again go to continue the chat in the chat box if anyone has any further questions for Christina. And we're going to move on to the next presentation. Thank you.
Thank you.
Our next two presentations will be here from Microsoft. And the next one is from Jay Beavers on the Microsoft ecosystem. I would like to mention that we recently lost Pat Quinn. As an ALS community, I think many people knew who he was, but when you see the video, you'll have another glimpse into his life.
Hi, my name is Jay Beavers, and I'm with Microsoft, and I'm happy to talk to you today about some of our work with assistive technologies. My team is called the Microsoft Research Enable Team. We were formed about 5 years ago to help create technology for people with motor neuron disabilities, diseases like ALS, Lou Gehrig's disease, etc. Now, our inspiration is a young man named Steve Gleason, who used to play football for the New Orleans Saints and was diagnosed at a relatively young age with ALS, or Lou Gehrig's disease. Steve came to our attention because he used technology to overcome his disabilities. And he had a few challenges that he wanted our help with, so he asked us if we could help him speak better with his wife, play with his son, and control his wheelchair. Steve uses a technology called eye tracking. Eye tracking are essentially specialty video cameras that use infrared light and little emitters, or essentially flashlights, to help isolate the pupils and tell where you're looking on a computer screen. For example of how they work, this is a photo of my son, and you can see how the flash from the camera is reflecting strongly directly in the center of his pupils. It's essentially this technique that eye trackers use. Here's an actual image of my face using an eye tracker. You can see that at the bottom of the screen, to the left and the right, there are little red LED lights there, and those are causing 2 dots to appear in each of my pupils. And those are very strong light signals, and that is what the eye tracker is using to isolate where my eyes are and help tell where they're looking. Now, at Microsoft Research, we have a new project which we call Deep Eyes, which the goal of this project is to bring no-cost and high-quality eye tracking to every Windows device. It's using a new approach called convolutional neural networks. Now, convolutional neural networks is essentially a mini brain. It's using machine learning and artificial intelligence to do the same thing that these specialty cameras were doing before. This project started back in 2016 as a research project from MIT called Gaze Capture. And how it works is we extract the right and the left eyes from the selfie cam, as well as the face location and orientation, and we feed it into essentially this mini brain. It kind of works like the cerebral cortex, and that predicts where we're looking on screen. Now, one of the challenges with this technology is recognizing the eyes and facial features. So here are 3 photos of famous people who have ALS. We have Stephen Hawking on the left, Pat Quinn, who's one of the people behind the Ice Bucket Challenge in the middle, and then Steve Gleason on the right. In these photos, you can see that in 2 of them, the algorithms that recognize facial features such as eye location, nose location, mouth, worked. With Steve Gleason and Steve Hawking on the left, it found their eyes, nose, and mouth. But in 2 of them, with Pat Quinn and with Stephen Hawking on the right, it wasn't able to locate their eyes. It got fooled either by the breathing apparatus that Pat is using or by how Stephen Hawking was holding his face in the example of the upper right photo. We think we can overcome these challenges, and how we're going to do it is we've developed a data collection tool that essentially uses the built-in web camera of a computer like a Microsoft Surface, and as you look at that dot in the screen, it takes a photo and records where you're looking, as well as the image associated with it. We're going to distribute this in partnership with Team Gleason and collect a large amount of data from people living with ALS to help build this kind of data that goes into this mini brain. Now here's an example of where we are today. This is a photo of me looking at that dark crosshair at the bottom of the screen. And the green crosshair is where our neural network is predicting that I'm looking. And you can see that it's pretty close. As a matter of fact, the yellow circle is the prediction error of an off-the-shelf commercial eye tracker that's in use today. And you can see in this case that the green is inside the yellow circle, meaning that it's actually doing better than the off-the-shelf eye tracker. We think that this technology is going to open some new opportunities in the future. One thing that it's going to do better is it will work outdoors in the sunlight. Today's eye trackers use infrared light, which the sun washes out, so they work well indoors, but when you take them outdoors into a sunny day, they stop working. The other is we think that this is going to bring down the cost of this technology. Today, these specialty eye trackers cost upwards of $1,000 to add to a computer. In the future, you'll be able to use the camera that comes built in with no additional cost. And because it's a neural network that can learn about different people's faces, we think that we're going to be able to train it to overcome facial variances and occlusions like breathing apparatus so that it will continue to work even in extreme cases like we saw with Pat Quinn and Stephen Hawking. Thank you very much for your time today. It was my honor and pleasure to talk to you about some of the technologies that we're working on, and we hope to help make the world a better place through assistive technology in the future. Thank you.
Thank you so much. That is very cool, as Amber is saying in the notes. It's something that, of course, we're all very interested in, working with people with ALS MND, that we want them to continue to communicate and access their environment for as long as possible. So are there any questions that are coming in? I do have a question just about some of the timing, because certainly the sunlight issue is something that we've been dealing with for years now. It's somebody who wants to go out and use their eye tracker while they're at their child's soccer or football game. Where are we in that timeline?
Well, it's a research project. So as someone who works on the kind of bleeding edge of this, I get to wave my hands and say the future. So it's still going to be a couple of years out. There's a lot of promise in this technology, but we are also using new concepts in machine learning, and we require hardware that can run these kind of miniature brains. So some devices, like a modern iPhone, actually has a little new type of processor built into it that can run these neural networks, and some devices don't yet. So it's a technology that's coming, but it's kind of not completely distributed across every computer and every phone that you have today. So 3-5 years is kind of what I'm thinking is when we're going to see this become something more out there. We've been working on it for about, to give you an idea, we've been working on it for about a year at this point. MIT started the work in 2016, so we're already about 3 or 4 years into it. That gives you the idea that the speed that this is working. A big next step, as someone mentioned in the comments, is to make these brains work, we have to train them. And that means collecting lots of data. Mm-hmm. And making that data available to run through the computers to come up with what we call a model. So I think we're going to be spending about the next year basically doing data collection to build these models, and that will give us a much better feel once we have the data set collected.
Well, I think you're talking to the right group for that. If you need people to beta test, we know people who would be happy to beta test them.
That sounds great. We're actively working on shipping the data collection app right now. Our initial plans are to work with about 100 people living with ALS through Team Gleason. We're I'm working every day and getting the application ready to distribute to the first 10 of those people to get feedback and make sure that everything's working fine. So it should be in the next few months that we start to expand the collection of data.
So there are some questions, you know, you mentioned the different eye tracking. There are different hardware systems for eye tracking. Are you just using it as a generic term then, and it would work with multiple hardware devices?
In our case, we don't use eye trackers with this technology. We use the cameras that are built in that we're using right now. So the video cameras that we use for Zoom are the same video cameras we use for this technique. That's what's different about it, is we don't have to put a specialty camera onto your device.
So just to throw a little glitch in that, so we're talking about all these video calls and things that we're doing with our people with ALS MND, they are also using their cameras then for the Zoom calls. So if we're doing a telemedicine visit, you know, we're using that camera, and if they would also be using that as their device, would that, or is that being thought of at all? Is that on the?
Not yet. We're too early to you bring up a good point. So right now we're still working on getting the feasibility of the technology to make sure that it works. To give you an idea of how that type of scenario would work on many devices like a Microsoft Surface or on an iPhone, they actually already have a couple of cameras. You're familiar with them having 2 or 3 cameras on the back. Many of the selfie cams, we have 2 or 3, or not 2, but it's not uncommon to see 2 cameras on the front-facing camera as well. Typically, we're using one of them for video conferencing, and we're using one of them for, say, facial recognition technology for like authentication. So that would be how you would handle it in the future. But that's you're ahead of where we're at today.
I think there's actually quite a few questions coming into the chat box. People are jumping right to brain-computer interfaces. So, but there's a lot of excitement about looking at this just because of course, these issues. Now with the eye tracking, there are people also asking about vision problems. If somebody has a visual problem like macular degeneration.
Yeah, so that's something that I'm really excited about. This technology is one of the challenges with today's eye trackers is that they are developed and tested by the people in the company who create the technology. That's just how all technology works. You know, we all test it ourselves first. And so it works better with the engineers and the teams in the companies themselves. And so an example of how that has held us back a little bit with eye tracking is there aren't a lot of people who are software engineers who also wear a breathing mask. And therefore, you see situations like we saw with Pat Quinn, where the eye tracker or the facial recognition doesn't work for him because of the breathing mask, because it wasn't tested with anyone who has a breathing mask. Something that's different about neural networks is it works very similar to the human brain in that we don't, as a computer programmer, I write down a specific algorithm for how my computer is going to work. I'm going to look for eyes by looking for oval shapes approximately in the center, you know, approximately above my nose. A matter of fact, one of the reasons that the eye trackers don't work is that they first tend to find the point of the nose, and then they use the point of the nose and a little bit of geometry to find where the center of the eyes are. And so if you can't find the point of the nose, it's hard to find the eyes. Neural networks work more like a toddler, in that they kind of learn based on their environment. And it means that you can customize them to an individual person, just like a toddler would learn how to recognize his or her mom's face, right, based on their personal experience. So we can do what's called transfer learning or training to specific situations. And I think that's going to help a lot with these eye conditions that are causing problems with, say, about 1% of the people who try to use eye trackers today. Right. So I'm actually really hopeful that that's one of the problems we solve is, you know, you get it and it doesn't work for you because you have had some type of LASIK or some type of eye surgery. And that means that the eye tracker doesn't work for you. Well, in the case of a neural network, you can say, okay, let's take this and let's have it learn my particular face, my particular eyes, and it can adjust itself. So that's a big promise.
Right. And then, of course, it would have to adapt. So if that person then does get a mask, it would have to adapt. And so there were just some other people mentioning things in the chat specific to the ALS MND group, and you know how we would love to work with you and let you know of some of either our issues or things that we've come up with. One of the Lisa Brewing mentions that she's put tape on the shiny spots of the BiPAP Max so it doesn't reflect back. You know, just you know, we're also here. We're thrilled with the work you're doing, and again, we're here to help you as well.
That sounds great. I really look forward to working with all of you.
And if you haven't met Nick Goldup yet, you should.
Very good. Some of the other questions, are we working with other companies? We absolutely are. I spend a lot of time talking with Google, for example. Was on a call with them yesterday discussing a similar project. So we definitely reach out. We spend a lot of time working with eye tracking companies, of course, leaders such as Toby are great partners of ours. And we are committed to making this data available on an open platform, on research platforms, so that we hope not only can we use it to help develop these new neural networks, but we allow any other company or research organization to take it and learn from it. The area of artificial intelligence and neural networks is moving very, very quickly right now. And so I expect that I have very little monopoly on how to make it work right. I expect that there's going to be, 14 other people who actually come up with better ideas than I do once they have the data in their hands. So I'm looking forward to what happens with that over the next few years.
Excellent. Yeah, collaboration is key for a lot of these things. Yeah. And you're doing better reading at that chat.
Yeah, I'm trying to scroll down and see what jumps out here. Yes.
Any other questions for Jay? All right, if there are, feel free to put them in the chat. I kind of liken that to when we say, if you have any other questions, come up and speak to the presenter afterwards. In this case, since it's virtual, if you have any other questions, please feel free to put it in the chat afterwards. And with that, we'll move on to the next presentation. Thank you so much.
Thank you, sir.
Next, we are going to have another Microsoft, this time about Microsoft Experience Innovation from Anne Paradiso.
Hi, I'm Anne Paradiso, Research Designer in the Enable Group at Microsoft Research. Today, I'm going to talk about two of the projects that our team has been working on with members of the ALS community. Before we dig in, I'll give you a quick overview of the Enable Group. The group was founded in 2015 with the mission of creating technology innovations that empower and improve quality of life of people living with disabilities. We design and test our ideas in close collaboration with members of our user community and partners so we can better understand the impact of new technologies on users' lives. We have primary projects around eye control and multimodal inputs for people living with speech and mobility disability, and sound-based user interfaces for people living with vision impairment. The first project I'm going to show you today is a collection of Eyes First games that our team released last year on the Windows Store. So what are Eyes First games? Eyes First games are simple, popular games reinvented for what we call an Eyes First experience, which means that we've optimized them to work well with eye trackers and with eye gaze as a primary input method. The games are built on top of the Windows 10 eye tracking APIs and can be used with or without Windows 10 eye control. And the primary purpose of the Eyes First games is to introduce the basic skill of eye tracking to users. This is similar to the approach Microsoft took in 1990 when they shipped Solitaire along with Windows, so that users could have a fun way to get used to basic mouse patterns like clicking and dragging and dropping and things of that nature. I'm going to show you a video of Satya Nadella, CEO of Microsoft, and one of our partners and collaborators, Bernice Yu. And they're going to discuss how the Eyes First games work and give you a little demo and overview of the games and how to get them.
Hi, I'm here with Bernice from our worldwide commercial business to talk about Eyes First Gaming. Bernice, welcome.
Hi, Satya.
Eyes First Gaming is for anyone with disabilities surrounding speech and mobility, and so they can just use their eyes to play games and many other things. Bernice, you want to show us what Eyes First Gaming looks like?
Yeah, so these are really cool games I'm excited to show you today. The games are powered by Windows 10 eye tracking APIs for people to play with only their eyes. And then, as you said, eye tracking is especially important for people with speech and mobility disabilities. So we designed the games, want to provide the people a fun and easy way to play. So let me show you how the game is done. There are 4 games. My favorite one is Maze. I have Maze up here. So I just look at where I want the puppy to go.
That's pretty awesome. So it's just basically just your gaze that's driving that.
I'm moving nothing else. And now we have a very happy puppy home.
Well done.
Cool, right?
Yes, congratulations.
So cool. And I just showed a very simple one, but with each of the game, we can up the level of complexity to make it more engaging and fun. So here. So I just make it harder.
Yeah.
But if you complete this level, you can even customize to make it 50 rolls if you like. So
awesome.
Definitely up the challenge.
That's fantastic.
Yeah.
And then what else can one do with eye gaze?
Eye gaze is such important assistive technologies, and if people master the skill of eye tracking, they can use that for work, collaboration, communication. There's a range of assistive technologies out there.
Fantastic. Is there anything more you want to show us?
Yeah, so I want to show that the games are eyes first, not eyes only.
That's right.
So that means people can play using mouse and touch too, so family and friends can enjoy the same experience and play as well. And the games are helping people not to just learn eye gaze, but also have fun experience. We got feedback actually from people playing and share with us how much they missed the playing. Yeah.
Wonderful. And how do we get started?
Yeah, so to get started, we need a Windows 10 PC and compatible eye trackers, such as the one I have here. And the games are available in Microsoft Store for Windows for download free. And they are available in 200 markets more. So check out Microsoft Store and search for Eyes First.
Thank you, Bernice.
Yeah, thank you. Thank you,
Thanks.
Satya.
There are many potential benefits that Eyes First games could have for patients living with motor neuron disease or other conditions that result in loss of speech or mobility. I think one of the primary benefits is just earlier access to basic eye tracking technology so users can practice. Eye tracking competency, like any new skill, requires practice and repetition, and it's much easier to acquire that skill before somebody needs to rely on it to communicate. Because the Eyes First games were designed to support multiple inputs and combination inputs, users can swap between inputs depending on physical needs, environmental context, or device constraints. Another potential use for the Eyes First games is to use them as a baseline to compare new inputs. So one might want to compare, say, a head mouse and an eye tracker and see how they stack up in terms of speed, accuracy, and fatigue. There are a number of ways that the games can be leveraged in a clinical environment, particularly for speech-language pathologists, assistive technology professionals, or recreational rehab therapists who are evaluating users for eye gaze suitability potentially for the first time. We've had the benefit and privilege of collaborating with some truly outstanding clinical professionals who have helped us to understand the challenges and complexities that they face in their respective clinical practices. We do not believe that the Eyes First games and applications are in any way going to solve some of those problems. But we do think that we might be able to be a useful tool in a clinical toolkit. We're continuing to grow the Eyes First ecosystem by releasing our work into the open source and continuing our collaboration with our user community and our partners. We also mentor student developers and interns who leverage our platform and our experience to create and ship their own Eyes First games and apps or conduct their own research investigations. And finally, I'll give you a quick overview of what we've been up to in the area of creativity and expression. As you well know, many people living with severe speech and mobility loss spend a disproportionate amount of time inside. They often report feelings of isolation, limited self-expression, and reduced quality of life. The creation of art, literature, and music has been shown across educational, clinical, and therapeutic contexts to support growth in self-esteem, confidence, and cognition, resulting in improved quality of life. For many of us, engaging in creative or artistic pursuits is natural, it's not unusual, and it's easily accessible. Yet little work has been conducted to design expressive technologies for people with limited or no motor ability, where technology and creative expression are inseparable and are complicated by extreme constraints. One project that is particularly near and dear to my heart is our Hands-Free Music project. This has been an ongoing collaboration over a number of years with members of multiple disability communities, musicians, technologists, and a host of inspired and motivated partners and collaborators. I'm running low on time in the presentation, so I don't have time to go into each project in depth, but I'll show you a series of videos that might give you an overview of the evolution of the work over the last couple of years and where we are today.
We are Dangerfield Newbie.
That was the day my world was turned upside down. That was when I was diagnosed with ALS. Obviously a lot of negatives here, but it's been very interesting to see some amazing things occur in the aftermath.
I will use more cowbell.
My name is Willie Payne. I'm a music technologist and intern at Microsoft Research in the Next Enable group. I build musical instruments that lower barriers for people to express themselves and make music. This summer, I was tasked with developing a tool for people with severe motor impairments to improvise and perform using eye gaze as the only input method. So let me show you how it works. The Cyclops has 3 main screens: instrument, sequence, and audio effects. The instrument page is the primary page for producing sounds. The tiny red dot is where the eye tracker detects my eye gaze. When I stare long enough at a button on the screen, it will cause it to press, playing a sound. The grid of numbers has a very particular arrangement. First, I'm going to set it to the diatonic scale. When I move from left to right, I'll play the steps in the C major scale. When I move from the bottom to the top, I'll play the notes of the chords in the key of C major. And when I move diagonally, I play even larger intervals. Switching to the pentatonic scale results in fewer, larger buttons that are easier to gaze at. Changing the dwell speed can reduce the amount of time necessary to trigger a button, but can also make it easier to accidentally hit buttons. All notes that are played are automatically recorded into a sequence. When the play button is pressed, the app will start to loop the last 8 notes that I recorded. When the sequence is looping, any note that I hit will automatically overwrite the note at that sequence. The Sequence tab contains extra controls for playing with the loop. We can change the tempo to affect the speed of the music. We can add accents to increase the volume of individual notes, or rests to silence portions of the loop. We can even set the length of the rhythm pattern independently from the length of the number of pitches. On the effects page, we can fine-tune how our sound actually sounds. First, I'm going to add a distortion effect and increase the cutoff of a low-pass filter, which will make our sound crunchier. Then, I'll change the cutoff value of a low-pass filter. The Cyclops records our effects changes in real time, allowing us to play them back and change the effect while the sequence or other notes are playing. With just a few controls, the Cyclops is an expressive instrument capable of a wide range of sounds, all controlled and triggered just with your eyes.
As usual, I've run out of time, so I'm going to stop now so we can take questions. But I'd like to thank you for spending the time to listen to my presentation. And if you'd like to learn more about anything that I talked about today, you can find out more at the Microsoft Research Enable Group website, and the link is below here on the deck. Thank you so much.
Thank you so much, Anne. I think we're all still just trying to wrap our heads around everything that you just showed. Again, it's certainly an exciting instrument for people to use if they're not able to go about their usual way of making music. And a lot of the questions are about collaborations. Are you collaborating with other groups? But again, a lot of people are just saying wow and amazing and things like that. So
awesome. Well, thanks. Am I supposed to, what should I do? Should I answer the,
you should answer.
I'm going on 2 hours of sleep. I'm a little fuzzy in the mind right now. Yeah, so
okay, so if you can rest for a minute, and I'll also let you know that, again, the group you're talking to, we have people, if you have things you want beta tested, if you things you want trial, this is the group to talk to. We have people who are, you know, very interested in trying these things out, and either whether they're people living with ALS MND or they're clinicians working with someone. So now you can.
That's fantastic. Thank you. So wow, this is such lovely feedback, and it looks like you all are kindred spirits with our group. We feel the same way as you all here about, you know, the importance of focusing on the things that really truly matter in life. Being able to participate with your loved ones, being able to communicate and express yourself creatively, and particularly around music. The reason that we took on the Hands-Free Music Project was when we first started meeting with PALS, which is what we call people living with ALS. I don't know if that's universal with all of our audience, but we started meeting with PALS and going to clinical rounds and learning more and more about the needs of the users and what all of the different people love to do and everything. Everybody had a relationship with music, whether it was making music. We had music teachers, instrumentalists, people who just enjoy, you know, playing music or singing in church. Some people just enjoy listening to other people play music. And so we thought, well, yeah, why shouldn't you be able to be creative? Why couldn't we reinvent the creative pathways? And see what we might be able to come up with. And a lot of people thought that it wasn't going to happen. And we really enjoy that when somebody tells us that you can't do something. It's a great motivator to prove them wrong. So in terms of collaboration, in terms of collaborators, we've had the music project's been a small side project, and we've been growing it incrementally in the summer using our wonderful PhD intern program. You saw Willie Payne there, who's an absolutely brilliant music technologist who's at NYU, who came in and developed the Cyclops. And Willie, what was really great about it is Willie wanted to explore something with a lower barrier to entrance, but a very high ceiling of expressivity. And so he built this sort of complex, incredible instrument that can do all sorts of things. And other investigations have been simpler. Like we've been working with students who maybe have cerebral palsy and are trying to participate more meaningfully in their band class in middle school. So there are all sorts of different ways to approach music. And over the last several years, we've built, I think, about 6 different, I think, pretty solid working prototypes. And they've taken a lot of time just to be able to get us to be able to collaborate with our pals, especially our pals like Jeremy, who you saw in the video, who's one of our favorite creative collaborators. And it took us a while just to be able to launch some of these applications from his speech device because we didn't want him to take him out of that context so that he could use it to communicate. So we had to get some of these when we had to learn how to get these sorts of apps to open from, like, say, Toby Communicator Screen. And then some of the older devices weren't beefy enough to support, say, what you saw Willie do. That takes a fair amount of processing and computing power to do. So we had to do a lot of problem solving with that in terms of just being able to get this in front of our collaborators so they could start to try it and give us feedback. We've been working with Jeremy on music for a few years now, and have had to take a small break in the last few months because of COVID, actually in the last 9 or 10 months because of COVID. So we've been able to communicate some of our advances to him via Zoom and things like that, but we're really looking forward to being able to start this work up again, get back in the lab and start making more instruments and more music.
That's fabulous. So is this available right now for people to try?
So it's not quite like the Eyes First games, which are packaged, tested, shipped on the Windows Store, and are going to work with a lower barrier to entry. These are things that we're incubating and that we're hoping eventually to release. Some of them will go into the open source and would probably need some assistance to get set up, but we would be more than happy to collaborate with folks who might want to try one of the different interfaces out. They're in different levels of doneness. We have a couple of things that are pretty baked that we've been working on for a while, and a couple of newer things that we're continuing to change all the time and that are a little bit flakier. So everything ultimately will go into the open source. We want people to build on our work. If anybody knows any other technologists or even students or developers or creatives who are looking for projects and want to start to look at what they might be able to do with this, that's also possible. We had a student group from the University of Washington who we mentored for their final capstone project, and they built a musical instrument called My Visual Piano, which is available right now on the Windows Store. And they built and shipped that within 2 semesters. So because we have APIs and different developer tools and some sample apps and some things like that, and because we keep on incrementally building on each other's work, we are getting to the point where we're getting closer and closer to having this more easily deployed.
Excellent. Now I am going to let some people have to go to break because of if they're doing this from work or whatever. So I'm going to let, if you need to go to break, please go ahead and go to break. And don't forget that there's the network, the group networking that you can do. But if you would stay and answer some of the questions on the chat box, that would be very much appreciated.
Be happy to. And it looks like my friend Jay here is doing a great job jumping in on some of these other questions regarding the tracking devices and things like that. So the question that I'm going to take is there a tracking device required to be bought to use games? So when we look at the investigations, the research investigations and incubating new experiences and prototypes, we think ultimately, and the goal is ultimately to have them be what we call technology agnostic. So theoretically, in a perfect world, they would work with various eye trackers that you could purchase now, or they would work with some of the great work that Jay and his team are working on around some future developments around using different methods of eye tracking. However, for right now, we've been using the Tobii 4Cs because they've been inexpensive and they support our HID standard. And HID, as Jay's mentioning in here, is a set of standards that we collaborate with technology partners on so that it reduces a little bit of the barrier to entry to using an eye tracker. The ultimate goal to those is that you would get any eye tracker. This is the dream. You could buy any eye tracker that's on the market, plug it in, and much like a mouse or a keyboard, it would just work. But we're not quite there now. It sounds like the Tobii 4Cs aren't for sale right now, and Jay and his team have been working with Tobii to figure out what in the next generation of trackers, which trackers are going to support the HID and which ones aren't. But right now, if you have a 4C or a PCI Mini or anything like that, and you can go and get the gaming drivers from the Tobii website, you can, with some work and with some technical support, theoretically get one of these systems set up.
Okay, I think we are going to have to go to break. Are you able to type in the chat?
Sure. Yeah, absolutely. It's probably better because I'm going on 2 hours of sleep and I'm kind of rambling a little bit.
All right, thank you so much. And now, again, we're going to take the break and you're going to have time to network, and you can go to the group network where you do the group discussions, and you'll meet up with people for about 4 minutes. And then when that ends, you can just keep joining again. The second way to network is through the meeting hub, where you can meet up with one person, and people might be trying to do that with you right now. And then last but not least, feel free to virtually stroll through, and please remember to be back here at 9 o'clock for the 9 a.m. Eastern time for the next session. Thank you so much. to stop.
Hello, well, I'd like to welcome you back from your break, and I hope you've had a chance for a coffee and a little bit of networking. I'm sitting here feeling completely mind blown about the excitement and all the kind of technology and everything from this morning. It's been a wonderful morning, and so I hope we can carry on. And I'm going to welcome Umberto Mania, who's going to be talking about the anxiety shows higher and progressive role of ALS than depression. So thank you, Umberto.
Good morning, everyone. I'm Umberto Manera. I'm a PhD student and neurologist from Turin, and I'm pleased to have the opportunity to present the result of a study on the prognostic role of anxiety and depression in ALS patients. Some studies have already investigated the impact of psychological status on clinical outcome. In a study performed in 1994, a psychological status score was derived from 10 psychometric tests, comparing only high and low psychological scores, but without taking into consideration the specific, independent roles of anxiety and depression. In the last few years, the prognostic role of anxiety and depression has been evaluated in many neurological and non-neurological conditions. For example, in patients with primitive brain tumors, glioma, these two conditions were present in about 1/3 of patients, independently from disease stage and disability. Interestingly, in these studies, after adjustment for multiple confounders, an effect of overall survival was found. Considering ALS patients, specific personality traits have been found to be different from age-matched controls, partly explaining the general impression that ALS patients have a very mild character. Specific personality traits such as agreeableness are related to a faster disease progression and to a steeper reduction of quality of life assessment scores. The vast majority of studies investigating depression and anxiety were mainly based on cross-sectional assessment of both conditions and their relation to disease severity, to cognitive impairment, to age, and caregiver burden. Anxiety resulted to be generally more frequent than depression in most of the studies, especially in the earlier phases of the disease. Poor emotional well-being, defined by ALS assessment questionnaire, the ALSA-Q40, specific items, has been associated with a faster disease progression, but not clearly with a reduced survival. Also, premorbid anxiety was not significantly different in ALS patients compared to healthy controls, but interestingly, ALS patients show high levels of resilience. Using our data, we primarily investigated the prognostic role of anxiety and depression in ALS patients, adjusting our analysis for different motor and cognitive confounders. We retrospectively collected all the hospital anxiety and depression scale questionnaires, performed as a part of a neuropsychological baseline evaluation at diagnosis. HADS is a widely used scale specifically developed to be a useful tool for the detection of anxiety and depression in people with physical health problems. 7 items measure anxiety and 7 items measure depression. A score from 0 to 7 is considered as normal, a score from 8 to 10 is considered as borderline, and a score from 11 to 21 as abnormal or case. We analyzed the data of ALS patients followed by the Turin ALS Center over a 10-year period. We performed a correlation analysis between the HADS scale and many clinical features, such as age, sex, education, ALSFRS score, delta ALSFRS, onset diagnosis interval, and cognitive categories, stratified using the strong criteria for ALS FTD categories. Then we performed a survival analysis using Cox proportional hazard models, adjusted for the same clinical features and Kaplan-Meier curves. We obtained data from 569 patients at diagnosis. Median anxiety score was of 7 and median depression score was 5, a slight lower than anxiety. Using standard HEDS cutoff, we found that anxiety was present as borderline or defined in about half of the patients, while depression was slightly less frequent. Considering the severity score, the majority of anxious patients showed only mild to moderate anxiety. Median anxiety scores resulted to be significantly higher in spinal patients, while depression scores did not differ significantly according to the site of onset. Anxiety and depression resulted to be moderately correlated among them. Depression resulted to be positively correlated with age and cognitive impairment, and inversely related to total ALSFRS score, while anxiety showed only a mild correlation to total ALSFRS score. Considering univariate analysis, both anxiety and depression resulted to be related to overall survival. Adjusted Cox model showed that anxiety, but not depression, was related to a higher risk for death tracheostomy. The best discriminating cutoff for the HEDS anxiety was 6, a score lower than borderline case, that confers the patient an hazard ratio of 1.45. We then analyzed the effect of depression in patients stratified for anxiety subscore, and we found, interestingly, that depression resulted to be a prognostic factor only in patients with comorbid anxiety, with an hazard ratio of 1.57 for the HEDS score higher than 6. In conclusion, we found that anxiety is more frequent than depression in ALS patients at diagnosis, and unlike depression, it seems not to be related to specific motor and cognitive features. We also point out that anxiety plays a role as an independent prognostic factor in ALS, similarly to what observed in both neurological and non-neurological conditions. Considering our data, we ask ourselves what are the interpretation of our findings. A possible explanation is that anxiety and depression lead to a reduced survival by worsening quality of life, motivation, therapeutic adherence, as it is already seen in other non-neurological disorders such as coronary heart disease and leukemia. In this case, mood disorders act like independent worsening factors. Another explanation is that both anxiety and motor neuron loss are manifestations of neuropathological involvement of common neuronal pathways. The neuronal circuitries of anxiety and mood disorders are located mainly in the frontal and prefrontal cortex. Recently, brain areas like amygdala and medial prefrontal cortex, that are important nodes of anxiety pathways, have been found to be altered in patients with ALS and primary lateral sclerosis. In this case, anxiety could be considered as a proxy of extramotor involvement in ALS. A third possible interpretation is that anxiety could negatively affect disease progression by enhancing neurodegenerative mechanisms such as neuroinflammation and excitotoxicity. Considering this intriguing hypothesis, anxiety could be considered as one of the determinants of disease progression. In this case, treating anxiety might be helpful not only to improve quality of life, but also to slow down disease progression. Our study is not without limitation. Principally, we still haven't completed the collection of longitudinal HEDS assessment and the use of medication for depression and anxiety. Future studies considering biomarkers, neuroimaging and neurophysiological techniques are needed to solve our unsolved questions. Thank you very much for giving me the possibility to present our data. I would like to thank all my research group members, especially our neuropsychology team, and you for your attention. Thank you very much.
Thank you, Umberto, for that very interesting presentation. Are there any questions for Umberto? So Umberto, while we're just waiting, because people are still on the chat, you'll be able to see them coming up. But do you have any advice for, on a practical level, with knowing this knowledge, for specialist teams, specialist nurses like myself, that how we could actually use this to help our patients when we see them in clinic?
Yes, the results of our studies are particularly interesting because anxiety is now considered just as an epiphenomenon and mainly related to the burden of the disease. But using this data, we also think that anxiety and depression could act also in the worsening of the disease. So patients with anxiety have a different disease course compared to patients without anxiety. Considering our data, we are not able now to weigh the effect of the therapies of anxiety and depression. We are not able to measure it, but we are now collecting all the data because for this specific study we analyze only the data obtained by using the scale I mentioned, the HADS, and we are now collecting also the data on drugs. And as a neurologist, and important to support patients in measure with anxiety and depression, and we have the sort of clinical. We start this study because we have the clinical impression that patient without anxiety seems to get lesser worse than patient with anxiety and depression. So. We usually use medication and psychological support for anxiety and for depression in ALS patients. And as a neurology, we see that not only the psychological status of the patient get better, but also the motor part of the disease is better when the psychological status is controlled, is treated. So is especially in the last years, we pay a particular attention to the psychological status of patients. We especially checked it.
Thank you very much. And there's from the chat, I think it's Becky suggesting that you get together with the previous speaker for some collaborative working.
Yes.
I think that may actually work towards helping your patients a lot.
Yes.
And it's people are just saying, and Anna, who the previous speaker, just saying how important it is, and she'd very much like to work with you. So I just have one other question. Actually, you talked about at the beginning of your presentation about resilience and how that was actually surprisingly high. Why do you think that is so? It's a high.
We don't know, because the study I mentioned is particularly interesting because it's the only one who specifically measured resilience in ALS patient in a premorbid condition. So it was a retrospective questionnaire, and we tried to measure the capacity of patient that after developed ALS. The measure used tried to explain the differences in the possible burden of stressors in previous life that can cause ALS, but they found quite the opposite. So it seems the ALS patient has a higher resilience than normal control, and it's probable that patients with ALS have a different genetic background. This is a possible explanation, but we actually don't know what is the correct answer for this question. I think it's very interesting, but it's the only one study available so that measured that.
Okay, well, thank you very much. That was a really interesting.
Thank you.
And I think you and Anna are going to have your work cut out for you in the future. So thank you for that.
Very much.
Would you mind, and as Sarah was saying, would you mind keeping an eye on the chat and answering any questions that
yes.
Following this your talk? But
yes,
thank you very much.
Thank you very much.
Really.
I'm here.
Bye.
You. Bye. Bye.
So now I'd like to introduce you to Catherine Pinto, who's going to talk about coping and living well with MND.
My name is Catherine. I'm a PhD researcher at the University of Southampton. I will be talking about my PhD research, which is looking to develop an online or digital intervention to reduce emotional distress for people with MND and their family members. The psychological impact of having MND can be huge, ranging from things like anxiety and depression to issues with adjusting to changes and symptoms. And the emotional side is really important because it can undermine quality of life. There has been some research into psychological therapies and interventions, but a lot more work needs to be done to understand what interventions are effective for this population. So I'm looking to develop an online intervention to provide some psychological support. And we chose this format because it would be easy to use with people who have varying levels of disability, and also in cases where accessing psychological therapy may be difficult. This, of course, doesn't take the place of face-to-face therapy, and some people will always prefer talking to someone face-to-face. This is just another avenue of support that people can use if they feel stuck and want to try something out in a more self-help format. We also used an approach called the person-based approach, which basically involves using qualitative research methods to understand the views of people who will be using the intervention at the different stages of developing the intervention. So this is an overview of the project. I started out by doing in-depth interviews with people with MND and their family members, mainly about their experiences of emotional distress and well-being. And I will be talking about this study in a bit more depth in this presentation. I also reviewed literature about people's experiences of using interventions and then pulled all these findings together to design the intervention. And I'm currently evaluating the intervention, trying to see how people respond to it and what they feel about actually using it. In my first study, I interviewed 25 people with MND and 10 family members. We managed to get quite a representative sample, including people who had been recently diagnosed and those who had MND for years. We also included people who couldn't speak and took part in written interviews. So we were able to get a good picture of people's emotional experiences at different stages of MND and with people who had a variety of symptoms. So these were our main findings. We identified 4 main themes that relate to emotional distress and 4 main themes that relate to emotional well-being. I won't go into too much detail about the themes related to emotional distress because I think most of you work in this field and are probably already aware of the issues that people face. But if you have any questions about the themes about emotional distress, I'd be happy to take them. I wanted to focus on the strategies that people used to improve emotional well-being because I felt that this was the area that I could learn the most from and actually apply as a healthcare professional. An important strategy people used was to look for hope and positivity, even if this was not found in terms of, say, medication or finding a cure. Having some options was really important and linked to hope. For example, the person in this quote says, "You always want to think you have options, got somewhere to go, because at that point where you think, well, I've got nowhere left to go with this, that's when you may sort of deteriorate and let it get the best of you." The person goes on to say how options for him was taking part in research and doing some physiotherapy. Some people also find hope by continuing to do activities that are meaningful to them and also continuing to focus on the positive. And the key thing is to have something to look forward to. This doesn't have to be something big. It can be little things like normal activities, spending time with family, having a weekend away. But having something to look forward to was linked to this need to maintain hope. Especially in a disease like MND, where control has been taken away, exerting some level of control over things was really important for people. For some, this was about control over how they lived, so doing tasks independently or trying to maintain a normal routine. But for some people, this control was about the approach they took. So some people preferred to focus on the present moment and what they could control, rather than thinking about the future and what might happen or how they would manage. Some people also exerted this control by actively making decisions about their treatment and care. And I think the important message for us is that a sense of control was important for everyone, even though people may express this differently. For example, some people may want information about the future, whereas some people actively avoid thinking about the future and wanting that information. But at the bottom of all of this, a sense of control is important. Another thing people mentioned in the interviews was that it was important to find a way to also be kind to yourself. For some people, especially family members, this meant taking a break from caring tasks. For people with MND, this would mean spending certain periods where you avoid information about MND. Sometimes being kinder to yourself also meant changing expectations of what could be done. So for example, the person in this quote says, "I let my body do the talking, and I was advised as well by the OT lady, saying, you can't work an 8-hour day anymore, because you'll be exhausted at the end of it. So work an hour or two, have half an hour break, especially when working from home. So I go and sit on the bed and sort of just chill for half an hour, till my hands and everything sort of go back to normal, and carry on with it." So sometimes just giving people the permission to almost take a step back and be kinder to themselves was also really useful. Support and compassion from other people was also really important in terms of emotional well-being. In terms of care, particularly depending on the care that people receive was important. The person in the first quote talks about how getting equipment in on time was important and helped them feel confident in the care they receive. Empathy from other people, whether from other healthcare professionals or other people with MND, also went a long way in terms of improving emotional well-being. So overall, the key things that were important for well-being were hope and positivity, a sense of control, and compassion, both self-compassion and self-kindness, and compassion from other people. And it's important to keep these three factors in mind, and I will now show you how I use this in developing my own intervention. So the findings influenced both what went into my intervention as well as how I designed my intervention. The first thing I had to bear in mind was that the intervention had to be framed in a way that was positive and empowering. So less of an emphasis on the problems and more on what could be done and what support people could get. I also tried not to be too confronting about the future or what may happen. The online intervention also has a section on building positivity and meaning. And I think this shift of focus away from ability and what people can and can't do to what is meaningful for them was really important. The online intervention also has different sections and no set of sessions that people have to go through. So this gives people the ability to choose what they would like to look at and what techniques they would like to use. And this was important to accommodate people with different coping preferences and also people at different stages of MND. For the intervention, I also used approaches from mindfulness and self-compassion therapy. And again, this was based directly from the findings of my qualitative interview study. So I'm just going to show you a couple of pages from the online intervention. This is the home page where people can choose from 3 sections: building positivity and meaning, adjusting to changes, and dealing with worry and stress based on how they are feeling at the time. If someone has a particular technique that they really liked or that worked for them before, then they can access this technique directly from the All Techniques section. Each section then is broken down into different activities and bits of information. So for example, you can see the positivity and meaning section has 3 activities: pleasant activities, benefit finding, and values and goals. So people can use this intervention almost in a preventative way to stay positive and pay attention to their mental health. But you could also use this intervention if you were experiencing difficult emotions. For example, the other page is about dealing with anger, and I present a suggested technique as well as practical tips. So people who have different coping preferences can find something that's useful within that section. We've also developed this intervention with lots of support from our patient and public involvement members, whose photographs you can see on the screen. And we're now at the stage where we are doing some research to try and test the acceptability of this intervention and get feedback from people with MND and their family members. So I've put my contact details on the screen if you'd like any more information about the study or about the intervention. And also, if you have any ideas or suggestions of how to best use an intervention like this in combination with the usual care that people receive, I'd love to hear from you. So please feel free to comment, ask questions. I'd also want to thank the MNDA for supporting this study, and thank you so much for listening.
Right. Thank you so much, Catherine. That was really, really interesting. There are a few questions in the chat. One, Jackie's asking, is this kind of available to other professionals, and can they access this yet?
At the moment, it's still being tested. We've only just developed it, so I'm keen to get feedback from people about whether it's useful and how they've actually used it. But eventually, yes, that's the aim, to implement it and get professionals as well using it with people.
Oh, that's really interesting. And I like the thought of it about mindfulness and being in the present and control, and being kind of having that control. Do you think actual mindfulness techniques and teaching can help enhance that control?
Yeah. So the actual website has a couple of these exercises to teach people mindfulness. But sometimes it doesn't have to be doing an actual meditation as well. A lot of people spoke about just having a mindful approach to life and how they do their daily tasks. And I'm sure that's something even healthcare professionals can teach people without actually maybe doing a whole meditation session or something like that.
No, that's really helpful. Thank you. And I think it's very timely that you should be looking at something online because I mean, from now anyway, that the paper, we're relying more and more on virtual therapies, and we find them very, people find them very accessible too. So that's interesting, and I suppose that's yeah, an extra added bonus to your work. Just see if there's any other questions. People are really saying an excellent presentation and thank you. And yes, the website would be useful. I think you've given your contact details in the presentation, but if you could possibly add your contact details to the chat, then people will find them available. If that's,
yes, I think I just did.
That's lovely. Are there any other questions for Catherine? Yeah, no, people are basically thanking you for that, for their presentation. So thank you very much, Catherine. That was really interesting.
Thank you.
Thank you. Okay, so yeah. So next I'd like to welcome Miriam Galvin, who is going to talk to us about individual quality of life among spousal ALS patients, caregivers. Thank you. Thank you, Miriam.
Hi, my name is Miriam Galvin. I'm from the Academic Unit of Neurology in Trinity College Dublin in Ireland. And I'm going to talk today about individual quality of life in ALS patient caregiver dyads. So just want to talk a little bit about, in the context of what's going to happen in this presentation, why is the assessment of quality of life important in healthcare, some issues around definition and measurement, and then introduce the concept of individual quality of life. And then we're going to focus on our study, which looked at the individual quality of life of ALS patients and caregivers. And we'll finish up by talking about the importance of assessing quality of life at an individual level. So why is the assessment of quality of life important? Well, progress in medical treatments and technology contribute to increased quantity of life. We also want to maintain and increase quality of life. Quality of life is seen as an appropriate outcome measure and desirable outcome of healthcare interventions. It is useful in health services evaluation and in healthcare delivery and facilitates person-centered care. So health-related quality of life looks at the impact of health status on life quality. Quality of life more generally looks not only at the impact of health status, but the impact of other features on quality of life. Quality of life is a subjective concept to which every individual attaches meaning, and those meanings also vary among individuals. George Kalman in the 1980s devised what is now called the Kalman gap, which is seen as the space between an individual's aspirations and hopes and what they experience in reality. Many quality of life measures use standardized assessments and pre-selected domains to assess quality of life of individuals. A challenge in measuring quality of life lies in its uniqueness to individuals, and values and priorities change in response to life circumstances. What is seen as important changes and depends, such as in progressive neurodegenerative diseases, aging, adapting to chronic illness, etc. Some examples of quality of life measures here. Before us, we were looking at the EQ5D5L, which is a descriptive system. It's over 5 dimensions: mobility, self-care, activities, pain, discomfort, anxiety, and depression. The patient is asked to tick the box next to the most appropriate statement in each of the 5 dimensions. Also, a visual analog scale records the person's self-rated health. The McGill Quality of Life Questionnaire is a 17-item questionnaire, again across 5 domains, and people are asked to indicate how they are in their physical well-being, physical symptoms, existential well-being, and psychological support and symptoms. Individual assessments, more individualized assessments, such as the SMILE and SQUAL. So SQUAL stands for the Schedule for the Evaluation of Individualized Quality of Life. Direct weighting is the version that's used here, and the version we used in our study, which we will talk about shortly. In SQUAL, respondents identify the areas of life which are most important to their overall quality of life. They rate their level of functioning and satisfaction with each of those areas. And then an overall index score quantifies individual quality of life. In the Schedule for Meaning in Life, Martin Flegg and colleagues in Germany devised the SMILE, which itself is a respondent-generated instrument for the assessment of individual meaning in life at the individual level. So we're going to focus more now on what is individual quality of life. So as I've alluded to, the definition of quality of life is highly specific, and individuals vary in the values they attach to different aspects of life. Quality of life is what the respondent says it is. Individualized measures increase respondents' ability to select the areas of life that are important to them, determine the relative importance of those life areas. So in our study, we looked at the individual quality of life of ALS patients and caregivers attending a clinic in Dublin, attending the National ALS Centre in Dublin. So as I mentioned, the aforementioned sequel was administered as a semi-structured interview over 3 interviews over approximately 18 months. So this longitudinal data collection, and we had mixed methods of data analysis. And below here we see the paper that resulted from that study. So who are these people? Well, there were 28 patient carer dyads, which is 56 people in all. They were actually spouses and partners of each other, and 28 spouse partners completed the sequel interview at 3 time points. So we see that the majority of patients were male, the majority of caregivers female. The site of onset, the majority site of onset was spinal onset for the patients, and over the 3 interviews, according to the mitos stage, there was relatively normal functioning among the patients at level 0 and 1. So in the sequel interview, people were asked, what are the 5 most important areas of your life at present? The things that you feel determine the quality of your life. They were also asked, why is that area important to you? So the important areas of life at the moment, the respondents were analysed, the content analysis of responses, and they were coded and classified into 10 categories. And here are the categories. So the categories, the responses to what's important in life are categorised into 10 life areas: family, friends, well-being, finance, hobbies, work, existential issues, faith, community, and other. So what are some of the important areas of your life at the moment? So I'm just going to look at some of those categories and what was involved within them, what comprised the categories. So for family, family consisted of, when people spoke about children or husbands, marriage, grandchildren, siblings, any other family members, was coded into the category of family. Similarly, health and well-being, it referred to issues to do with one's own health, the respondent's own health, whether mental or physical health, and also the concern and importance of other people's health. Social activities, sports, travel, television, etc. were coded under social activities that ranged from sports through to crafts and cooking. And response around issues such as hope, time and freedom categorized as in the existential category. So again, looking at the 5 most important areas in life of the patient's care dyads. So we see here that family was the most important overall for both patients and carers. But carers mentioned it more often than patients overall. And similarly for social activities, while it was second most important area for both, it seemed to be mentioned more often by patients. Note here that health, while the 3rd most frequently nominated important life area, but still quite a distance behind the 2 main contenders, so to speak. It's important to note the difference between patients and caregivers in some of these. So as mentioned, we asked, why is that area important to you? So patients who spoke about, say, these are some selected quotations to describe why patients that described the reasons why these things were important to them. So friends were important because they felt alive being with them. Our wife was important for this man because he loves her and that's it, even though she mightn't think it. His own health is important. I know enough still to enjoy myself. I'm not worried about the lack of it. Fishing, it's where you can go and make your own decisions. Nobody will tell you you can't go there or here. It's exciting. Free time, I can do things at leisure. No time pressure, and I have no responsibility. You have to believe in something. When you get to my age with this disease, you better. The disease doesn't bother me, and religion helps with that. For the caregivers, we asked, why is that life area important to you? So again, we look at some of the same categories, but for carers, friends provided respite. This person said I could talk to them, say things they wouldn't be able to say to the patient. They can give out. They don't have to protect the patient from their worries. Children are important. Who's going to be there for me during the illness? People she thought would have been are not there, but the children now are her support. This gentleman's own health is important to him, because as his wife is becoming more functionally and cognitively perhaps impaired, he needs to be fit while his wife is dependent. Walking keeps me sane. A carer who goes to work, I love what I do. I've cut back and I only work 3 days a week. It's a bit of escapism. Financial worries, there's not enough money to pay the bills. So we see here that the categories are comprised of different nuanced reasons why that category is important. And this is why this assessment, we believe, of individual quality of life is crucial. We get a sense of what matters to people, and we try to, in some way, to support the things that matter to them as best we can in the health environment. So those life areas for patients changed over time. As you can see, family still remained, was frequently nominated as being really important, as was hobbies. I think the social activities in general tend to be greater contributors to quality of life for patients. The common contributors, friends and finances are important, relatively more for carers than for patients. So an individual quality of life score can also be calculated for comparison purposes, if we like. And it's called the Individual Quality of Life, SIS, C-qual index score. It ranges from 0 to 100. So for these 56 people, 28 patients and caregiver couples, we calculated their individual quality of life. So we can go into the calculation. It's a specific way of doing it. It's a rating area and the relative importance, and that's available in the literature, just to let you know. So for these patients and carers, we see here that overall it was a very high, the median quality of life score was high for both patients and carers over time, considering it goes from 0 to 100, which could be seen as unexpected, I guess, for people who are in such a degenerative disease. Here we can see that graphically. It's interesting to note that caregivers have a lower median quality of life at all interviews. So just to conclude, we believe it's important to assess quality of life on an individual basis. We've seen the level and type of information we can get from using an individualized measure. Family can mean different things to different people and be categorized as family. And the importance of an individual method is the person gets to define for themselves what's important. We believe it's important to use an individual method in conjunction with the standardized measures as relevant, because they're individual, it's more difficult to generalize across groups. In clinical practice, we believe it signposts what matters to people in the care journey and over the course of the disease. Contributors to life quality are re-evaluated as patients and care partners adapt to changing circumstances. And palliative and supportive services should aim to support the factors identified to help maintain life quality as long as is practicable. So I'd like to acknowledge the patients and caregivers who participated in this research, Professor Hardiman, research and clinical teams at the Academic Unit of Neurology in Trinity, Beaumont Hospital in Dublin, and the Health Research Board in Dublin, Ireland. Thank you.
Thank you, Miriam, for that really interesting talk and discussion. Now, I'm just going to look and see if there are any questions on the chat before I jump in. Not just yet, but I'm just wondering, you're suggesting that this quality of life assessment be done on patients. And then once it's done, how would you advise the professionals looking after the patients can utilize the scores and the results? So it's
I think over time, it's obviously, if we have identified, just as to give an example, when I was doing some of these interviews, I visited a patient in his home, and he expressed to me that he had built a bird house in the garden. And that was really important to him, and it helped his quality of life. I went back the next time and he was further impaired and he couldn't turn around and see it. But he said, I think I can hear the birds going into my house. Third time, unfortunately, his sight had gone, but he knew it was there. So the same thing changed over time. So if I knew that bird houses matter to that person, for example, it may seem as small, but I just gave it to you as an example of change over time. I mean, the idea of assessing quality of life at the individual level it helps person-centered care, because we know what matters to that person. Obviously, it's possibly quite difficult if you have loads and loads of patients, etc. But if you document it initially, just in terms of interpersonal, you can ask people, how is it going? You can also monitor this over time, as we did in our 3 interviews. And I think it gives extra information to facilitate person-centered care.
That's lovely. And I think Diane would agree with you. She's in the chat is saying absolutely incredibly important thing. And the other thing I find fascinating, and I think it's just a kind of a sideline of what you were talking about, is the value and impact of friends,
Yes.
both on the caregiver and the person living with MND, and how they seem to change in their importance for people. And I think
so I think it's really, yes, and I'm hopefully doing more work on this as well, apart from the top line results. So what matters is, for example, even in the family, I digress for a moment, but even in family, it's interesting to note that, say, children become quite important for carers as things continue, but children are important for patients because they want some sort of legacy, or they're leaving them. So, you know, it depends on the importance each person attaches. So in the context of friends, I think friends, as one of the quotations illustrated there, it gives caregivers an opportunity to perhaps leave the house, but also to offload somewhat, because in the research I was doing, quite frequently one's own family or the family of the person for whom I'm providing care are also invested in the process. So this person was afraid to speak because the mother-in-law might be upset or whatever, whereas her friend that she used to play tennis with provided an extra familial, if you like, outlet.
Yeah.
So it obviously also helped social interaction for the caregiver, but it also helped in terms of another person to whom they could divest. So an emotional, if you like, support system to an extent.
No, that's really interesting. And Leslie Doyle would also agree on how important it is to highlight the quality of life, and to be able to talk about that in enabling us to manage people better. So lots of positive feedback, and agreeing with you on your feedback. So thank you for that. So thank you. Any more questions? I'll just wait one more moment just to see if there's anybody. Awesome presentation. Somebody saying, and yeah. So yes, I don't think there are any more questions, but thank you so much.
Thank you. I just leave you with the thought, if I may, Rachel. I think oftentimes people in practice are so overworked and everything, and something like this can seem quite intense. How do I get the time to do it? So, and also for clinical trials, for example, the idea of how do we actually do this could so individualized. So that's why I believe the combination. So we're not saying I'm not saying certainly that the standardized measures are irrelevant or not useful, but I believe a combination of personalized and standardized just gives us more information and perhaps facilitates more important care. So that just to leave you with that thought. Thank you very much for this.
No, that's a great point, because I think I really like, I mean, lots of the research obviously is fantastic, but to have something that's practical and we can use on a daily basis, or if we can't use it, that's in our head, and we can kind of implement it as best we can. I think it's absolutely brilliant. So thank you so much for that.
Okay, thank you very much for the invitation. Okay, bye-bye.
Thank you. Right, so this, I have the great pleasure of the last session. It's certainly not the least session. It's we'd like to bring, we're going to have a very interesting, I hope, panel discussion with some experts in the field of family and caregiving. So I hope they'll appear. Fantastic. So I'd like to thank everybody for being here and joining us today in the last session of this amazing forum. So Sarah, would you like to? Are you going to? Shall we introduce? How shall we introduce this together?
Yes, I'll stay muted and you can introduce it.
It's the best way.
This panel is on family and caregiving, focus on the children. I know we had a presentation earlier in the days that we've been doing this on a similar topic, and it's always a very requested topic for the Allied Professionals Forum. There are caregivers, there are allied health professionals out there, and people living with ALS MND who just want to know more about, what do we do with the caregiving, and specifically focusing on children. So when we were working up the Allied Professionals Forum, we thought that actually having a panel of people from the panel you'll see here who will introduce themselves might be a different way to do it this year, since we're doing the whole Allied Health Professionals Forum differently. And we hope you enjoy it, and we hope you learn something from it. So I thought what we could do is I was going to have you introduce yourselves alphabetically, so there was no there's no hierarchy here, and that would go from Melinda to Anna to Jody, which goes right across here. And Rachel, did you have anything else to add before that?
Oh, that's fantastic. I am so looking forward to this. Yeah.
Yes, Melinda, that means you're on.
Now I'm unmuted. Hello, good morning, good afternoon, good evening. What an absolute thrill to be here. My name is Melinda Kavanaugh. I'm a licensed clinical social worker and an associate professor in social work at the University of Wisconsin in Milwaukee. It's a beautiful sunny day up here in Wisconsin. I am so excited to talk with my wonderful fellow colleagues. The primary area of research and my clinical practice for many years has been focusing on children and youth who are caregivers across disorders, including ALS. So very excited to talk about some of the support programs and interventions that I've developed and learned from my colleagues who are here today. Thank you.
Am I next?
Yes, you
are. Hello, I'm Anna Kent. I'm a nurse specialist. I'm based in Milton Keynes, work in the community. I work with people with complex neurological conditions and motor neurone disease. It's an honour to be part of this esteemed panel. I think expert in inverted commas for me. And I've been working locally with our local hospice and more nationally with the Motor Neurone Disease Association in trying to draw up support for children affected by motor neurone disease. And yeah, so thank you for asking me to be part of this.
And then Jody.
Hello, and good afternoon, good morning to you, wherever you are. My name is Jody O'Donnell Ames, and I'm also thrilled to be here. I'm just excited that we are talking about children in this journey because it's such an important topic. I'm the founder of Hope Loves Company, the only nonprofit in the United States that has the mission of providing both educational and emotional support to children and young adults who either have had or have a loved one living with ALS. And my work is the result of losing my spouse, Kevin, at the age of 36 to ALS, and raising children and learning this, how important this resource is. So thank you very much.
So thank you for all introducing yourself. So I think it's really interesting about, we all know and we all understand how important caring for families are and caring for children in the holistic way we care for our patients. And I think it's something that bears on me all the time. And about 7 or 8 years ago, as a team, we thought we really must do something about this. We really must kind of get our acts together and do something really kind of good and helpful and change the way we work completely. So we gathered a team of professionals that would be involved, and we started to talk about it. And then we talked about it. And we talked a little bit more about it. And then we discussed how we could measure it and how we could fund it. And then we thought about the health and safety of it. And then we talked a little bit more. And as it went, 3 years went by and we had done very little. And then this Anna Kent comes along, and in front of my very eyes, she just goes and does it. And that's why I really want Anna to share and talk about actually, Anna, what you did, because you just didn't talk about it. You did talk about it, but not like us. You just did it. And I'm just in awe. So please, Anna.
Well, yeah. So in Milton Keynes, as I said, I'm based in the community, and I'm able to work with our local hospice, and we've got a really strong branch of the Motor Neurone Disease Association. And I became very aware that we had 4 or 5 families referred into me, or people with diagnosed motor neurone disease, and they all had young families, which was unusual. And having made the 3rd referral to the local hospice to gain family support, I thought, why aren't we getting these kids together? Because I'm sure they could provide so much more to each other than I can, because they know what they want, they know what they want to discuss. So fortunately, the people I work with within the hospice were like-minded. So we got together and we went, why don't we just do it? Just do it. We'll see what happens. If it's an abject disaster, at least we've given it a go. So we managed to get a free venue. We managed to talk to various parents who released their offspring, who are obviously very precious to them, for an afternoon where we went to the local skating rink. We watched a game of ice hockey, and we had an amazing time. We didn't do anything that was, I thought, really challenging. There was lots of worries about risk. Well, we knew it was going to be risky. It was ice. So parents knew that. They were up for that. The venues had done their risk assessment. We didn't have to do it. Working with the hospice, we had people that were skilled in dealing with children, and it gave the kids a gentle introduction. We managed to get funding by asking and begging. We talked to my children about what we should put in the goodie bags, because some adults thought a disposable camera would be really helpful. Obviously, that was a very different level of thought. So we talked to the kids. We knew there was a need, and we thought we'd give it a go. And as a result of that, we actually put on an afternoon which was so well received by the kids, and also the parents as well, and the people that attended. No one died. Everyone was happy. Everyone went home. They were fine. And as a result of that, I think we challenged a wider organisational opinion, because we realised that bigger organisations weren't asking, are there children in these families? If you don't know the audience, how can you actually do anything about it? So we just did it. And as a result of that, it happened. We didn't talk about it. We realised after the 3rd event, we should evaluate properly at the time. So we looked at different things. So we've worked, that was our top tip, asked the questionnaire at the time. But I think it's about being brave, collaborating and working with like-minded individuals to actually get going, because we can talk about it. We can go round and round in circles, give it a go. If it works, great. If not, go back and think about how it can be done. So cavalier attitude, I think.
Brilliant. Thank you. Thanks, Sarah.
That actually sounds a lot like some of what Jody has done. And you actually touched on it a little bit in the beginning when you were talking to Anna, and it came up when we were doing the pre-discussions for this today, where you all talked about the children feeling a little like they were isolated. Like they were an island. They were the only ones dealing with the fact that they had a parent or a grandparent who has ALS MND. So you just, talked about a little bit, and Jody, I'd like you to also talk a little bit more about that. Like, how do you demonstrate to them that they're not alone? And please, if Melinda, then you have also something to follow up, feel free.
Thank you so much for that excellent question. So how do you inform children that they're not alone? How do you diminish isolation and worry and fear and all of the feelings that they're going through, and many times going through privately? You know, they may not want to share how they feel with their sick parent or their even well parent, because many times children want to be brave for their families. So I think just introducing them is key to other children, giving them the opportunity to have a voice in a group sharing, giving them resources for communication within your own home. The more that they recognize that there are other children out there of the same age, also with parents just like their mommies and daddies, they will feel less isolated. And I think that the best thing we can do as adults and as professionals is to bring these resources to children. And at Hope Loves Company, this is our focus. We provide many programs, including Camp HLC and group shares and Hugs of Hope care packages, and everything that we do is specifically focused on eliminating this challenge of, or eliminating this feeling of, you know, being the only one who has a mom or dad who's sick. I also think that it's really important that we try to work together in this realm. You know, allowing your families to know what programs you offer and making them really accessible, so that when they're doing the research, they know here are all of the ways that we're supporting families and with children, so that they can have access and utilize those programs.
I agree with everything that Jody has said, and all of the work that that I've had the privilege of being a part of, either as the developer or engaging with. The critical piece is to get peers with peers, so that children are engaged with like youth. So when we are doing a camp or we're doing a support program, they get to actually see face to face that there is someone who is in their similar situation. And in the youth training, Y-Care education and training program, it's all done in peer groups, because we found very early on that that is the integral piece, and the critical piece is that making sure they can see and talk and engage with peers who are just like them.
Mm-hmm.
Thank you. Melinda, I would just wonder if you can also kind of express and explain some of the your experiences that you within your work about children with anticipatory grief.
Yeah, I tell you, this is a huge issue and does not get discussed much, even in the end of life and death and dying conversations. So anticipatory grief is really when someone is expecting a death. Right? So those feelings are manifesting that they're grieving this loss that hasn't yet happened yet, but they know it's going to happen. So when we say they're grieving the loss, those losses are things that are so very powerful to children. They're things like their parents' voice, hugs from their grandparent, activities that they always engaged in with the family member who has ALS, who they know that they're losing, but they're really losing those experiences. So what we need to tell children is it's okay to grieve in general, and it's also very much okay to grieve those anticipatory losses and to talk about it and to share it either with other peers, with their school personnel, but understanding that parents often really struggle with this concept because we all want so much to hang on to what we have at that moment. But acknowledging is really important for children, acknowledging that those losses are happening. Sometimes they're incremental and sometimes they just hit all at once. And the person's still there, but these are very important incremental losses that children are experiencing on a daily basis. And we as a society, but also in healthcare professionals, don't always acknowledge those individual losses. So what we can do as professionals is think ahead. Everybody needs to think ahead in this space. So it's about what supports can we provide the children while they're going through these things, being very open and honest and acknowledging that those are losses, even before the person who's living with ALS dies. Those are very important. And sometimes those, what we might consider incremental or small losses, are often way more important to the child than we might acknowledge as an adult. So there are a number of resources for children. Particularly, I've worked really closely with the ALS Association, and we have a whole series of books for children across ages. And in every single one of these books for children and youth, we address it head on. We say that these are losses that are happening. Talk to someone about it. We have a new book out for school personnel where we again hit it head on and say these are children who might be struggling in class because of that anticipation of the full-blown grief. But these anticipatory grief moments can be daily unsettling and really difficult if we aren't willing to step in as professionals and acknowledge them and do what we can to support them.
Yeah, absolutely. And, you know, the presentation earlier this week, they mentioned the memory box idea.
Mm-hmm.
And I wonder if that, you know, if even bringing up something like doing the memory box and asking the person those questions, if that in itself doesn't trigger at least a conversation then about it as well.
Absolutely. And just reminding ourselves that grief is not a dirty word, and that anticipatory grief is certainly not a dirty word. And with children, we tend to tiptoe and we tend to be afraid to bring up some of these things. So the memory box is letting them explore and really sit with the love that they had with that individual and sit with the things that they have lost, but that they can talk about and share. And so they don't feel like they're in an isolated island, as Jody said earlier.
Mm-hmm.
Absolutely.
I think that was really good when you could see the children interacting with each other and having those conversations. Absolutely. They were fine. They were absolutely fine. I think it was the adults around going, oh, this could be challenging. In fact, the kids were able to sort themselves out. I think sometimes we're too worried about perhaps giving it,
We're very much too worried. Kids are often light years ahead of us.
Absolutely, because they know what's going on. You know, they have access to so much information. So yeah, I think we have to acknowledge the fact that the children often know what they want and how to access that, and that peer support. I just, you know, from the opportunity to meet up is so important.
And in social work, we often say, meet our clients where they are. So meet them where their needs are at. So working with children in these families, meet them where they are. We don't need to make assumptions where they are because we, as an adult, have our own preconceived notions, but really meet the children where they're at and go from there.
Yeah, so that actually...
I think we sometimes underestimate their resilience really to all of this.
Absolutely.
Yes. So
absolutely we do.
But that also leads me to, you know, you're talking about bringing up the children and talking to the children, and you know, you mentioned you're a licensed social worker, but you know, we're in the clinic itself then too. We have the allied health professionals. You know, you have myself, and I know when we first started working with this years and years ago, back in 2004, we had a Marlene Shahosky was our mental health specialist, and it was really also a very big love of hers. But the rest of the clinic team wasn't necessarily as comfortable, you know, bringing up these things. Like Anna said, you know, they're okay talking about, but we maybe aren't. So what is some guidance that you can give us to get over that fear or that hesitancy so we're more comfortable engaging with the children?
Well, I would love to start with answering that question, and thank you for asking it. And I'd like to say that, first and foremost, recognize that you have to ask. You have to ask in that family if there are children. When you go into a home and you do a home visit, ask about the children are a part of that family. They are a cohesive unit in this journey, and they are really, really important. So start with asking. And then if you're concerned about having this communication that feels authentic and open, have something in your toolkit, have a stuffed animal, have a game, have something that children like. Get the lingo, the language down, know a video game that might be appropriate for that child's age.
Absolutely.
And just,
not a camera, not a disposable camera.
Not a disposable camera. Put your flip phone away, Sarah.
Right. Use language that's appropriate for that child's age. Use body language that welcomes that child. And really just think about the fact that they most likely know more than you anticipate. They most likely are doing much more than you think. We have seen at Hope Loves Company children as young as 3 providing feedings. We have seen children as young as 6 helping with toileting. So these are children who are very aware, most likely, what ALS is and the impact it's having not only on the person they love, but in their entire family. So, feel free to just be a friend to that child and allow, it's not that you have to say, I'm here for you. You don't even have to go there. Just be a person of presence, of compassion and understanding. And that child will intuitively know that you care. And I think that it's a really subtle invitation, but I think that it can be extremely powerful.
I just add very quickly, I agree everything that Jody is saying. I will say that when I've worked with a lot of healthcare professionals on our Y-Care youth training and support program, and so many of them come into it and say, I don't know, I've never really worked with kids. I'm kind of, nervous. They get into it, and these people are amazing. They are so extraordinary when they just kind of jump in and have these conversations with the kids. But what I see is the flip side. I see how excited the children are to be able to know what an occupational therapist does, what a physical therapist does. What do you mean you're a respiratory therapist? They're engaging in learning about the professions. They're feeling confident because they have this big professional person helping them learn these care skills and tasks. And then they leave and they feel like, wow, I could actually talk to this professional. Whereas before, I didn't know enough about them. I didn't know how to communicate with them. So I'll just add that it's a real two-way street here, that we want the professionals to build that confidence and that encouragement to just talk to them, as Jody said. But when we see that happening, the kids blossom and they really feel like they have something to say and someone's hearing them. These important professionals are hearing the kids. And that's something that we just cannot put any sort of dollar sign on, because they're now part of that conversation in a lot of ways they've never been. So just to point up that two-way street that goes along.
And just to add to it, no one's expecting you to go in as an expert. It's starting that conversation. It's knowing the resources that you can then refer into, because then you're not going to have to hold that on your own. It's starting the conversation, working in collaboration, and just dipping your toe in the water, don't ignore it. It's there. And I would also say, not just children in an immediate family, but grandchildren, think about the extended family. And the other thing I'm really passionate about is the fact that these are our future. These children are our future. These could potentially be our future therapists, nurses, social workers, researchers. They're our future. So I think we need to invest in them.
Mm-hmm.
I want to just add very quickly, you're absolutely right. And many of the children become nurses and doctors and physicians because of the experience of being a caregiver as a young child. We've seen it again and again. Also, perhaps consider, and I want to give a quick kudos to many people on this call in the chat, because you have definitely demonstrated this at Camp HLC and at these programs that we're all speaking of. So thank you so much for demonstrating these qualities. But also recognize that you can have a quick meeting as a staff, as a team, as a clinic on how to talk to children, how to, when you go into a home, how to address them, and just have a quick conversation about it, because that may help to alleviate some of the fear.
Yeah, can I address one of the questions in the chat? Rachel, is that okay with you?
Yeah, of course, go ahead. Yeah.
If you ladies as well, somebody is asking about getting people to be ready for the conversation. And I think that kind of fits right in to this conversation now. So I don't know if you've seen it, but some people are willing to talk, but some people aren't.
Are you referring to children or to adults?
I understood it was from adults talking to children.
Mm-hmm.
Is that correct? Yes. Well, I don't know. I just say my personal opinion and let Anna and Jody jump in, but I'll just say really quickly, I don't think that there's a perfect time and there's no kind of definitive preparation. That the key really needs to be normalizing conversations. Do it when you're randomly watching TV or having breakfast, something where the kids are just kind of normally living their lives. Make it a part of your daily conversations, because if you separate them and make a really big deal out of it and say, now we're going to have this really important conversation, then the kids are kind of worked up. You're a little worked up as the parent. Sometimes that's where we see a lot of anxiety and some potential conflict, but just make it a part of your daily conversations. How are they doing? Check-ins. This is what's going on. So those are the first things I'll say, and let Jody and Anna jump in.
Yeah, I was going to say that if a parent or grandparent is really uncomfortable initiating this conversation, perhaps find someone who can. Because you do want to have communications. You do want your child or grandchild to be prepared and to feel like he or she can talk about this. Their minds are probably worried and concerned, and you want them to have that open communication. Also, having this discussion with a book in place is great, because when children read, they can connect to characters or with characters in the book. And intuitively or authentically, they will ask questions related to the character in the story that will help encourage this discussion. So just even beginning with a story, a children's book about ALS, or as Calamite and Melinda mentioned, the ALS Association books. This will be a great resource and tool to beginning a gentle conversation.
And I think also based on that, and based on the work that's been going on in the UK, the Motor Neurone Disease Association have really developed some really good resources now, including an interactive website, MND Buddies. But I think, as you're right, people don't have to do it on their own. There are other sources of support. But I think it's making it normal and not making it a huge, great big deal, because again, children will often have found out a lot more than we give them credit for.
Right. And one thing I want to address, someone made a comment about keeping them ongoing. Oh, that is so critical. As the disease progresses and changes and new things are happening, keep that conversation going. It should never be kind of a one-off or kind of only on occasion. If you normalize it as part of the daily conversation in our life, and our family's experience, then you can build on those conversations and have them as things change. And then we get to that point where we talked earlier about the anticipatory grief and the loss. And you've really built up this kind of foundation for the children to be able to have those conversations. I just wanted to acknowledge that. And I think someone made a really nice comment in the chat about that.
Mm-hmm. We had a patient recently who was having real problems eating and drinking and swallowing and speaking, and clearly needed a peg. And we discussed it and he agreed, but he wouldn't have it because he didn't want to upset his son. And he didn't want to have his son look at his peg, and it went round and we talked and discussed it. And this went on for quite some time. And then he came back and he said, okay, I'll have it. And I said, okay, so what's changed? And he said, my son said to me, do you know what you need, Daddy? You need a hole in your tummy. And it's like, right, thank you very much. And he had, the son had no idea about pegs, but he had a solution. So he knew, and had they only been able to talk, and all the help that we tried to give them to enable them to talk to each other, the child did it on his own, really.
Mm-hmm.
So,
I just want to add too, if you don't mind, piggybacking on both, is that recognize I raised 3 very different children who dealt with grief differently.
Yep.
So recognize that within your own family, that your children may react to these discussions and have separate needs. So it's just something to be aware of.
Mm-hmm. Absolutely.
Judy, thank you. And just kind of leading on to that, I'm going to ask you all if you can help us to understand what happens with children when they're no longer kind of having that caregiver identity, and can you give us practical strategies for helping us to deal with this?
Mm-hmm.
Shall I start with Melinda?
Yeah, so I think the very first thing we can do is continue the openness in the conversation and let them grieve and express how they have felt being a caregiver, how they feel maybe now that they're no longer a caregiver. We need to, in general, normalize the caregiving situation so that it's not an awkward, uncomfortable, difficult thing to have a conversation about. But second of all, we need to recognize that when children are providing care, frankly, when anyone's providing care, but particularly when children are providing care, they're often really developing a sense of confidence and a sense of care and love and nurturing to that person or to other people. And so while you want to make sure they have that time to grieve the loss, to be able to really feel that, you also want to be able to encourage them that they've done some amazing things. And how can you continue that, whether it's volunteering somewhere or, a lot of the children in our families in ALS are deeply involved in advocacy and fundraising programs. And it's never anything that we should require the children to do. But what I'm saying is that helps tap into all of those feelings of altruism and care and compassion and confidence that they built up that you want to encourage. And as Jody said, a lot of the youth end up being social workers or nurses or physicians simply because they've really developed that. And so it's important to encourage that and not shut it off and say, okay, now that someone has passed away, you're no longer the caregiver, so just go back to being whoever you were before. And the truth is that care has really deeply embedded into their identities. Whether they want to be a caregiver again or not, we need to acknowledge what that's potentially given to them in their lives as a child and a caregiver.
We've also noticed that some of the children who've lost family members through MND have actually come back to some of the events that we've held, which has been really good. And I think that's been hugely important, that the children were still included in the invite, and then they self-selected if they wanted to come along. And so I think we weren't, again, too exclusive. I think that was really important.
Yeah, and I'll also add that the whole idea of Hope Loves Company is to provide the resources that children need during this journey, which is included after loss. And what we have seen, which is just an amazing thing, is that the children we serve do outgrow our programs, and they come back to volunteer, to be ambassadors, to be a voice, to be proactive. And we are very proud to say an example of this success is that we now have our first board member who was a child caregiver. She lost her mom to ALS in 2015, attended several of our camps, our ambassador program, and now she's a board member. So that is really the goal that we all have here, is to provide the resources that children need to be healthy and to feel good about what they've done, and to provide these resources eventually in assistance perhaps to children who are now experiencing what they did, to be able to maybe give it back if they're comfortable doing that. And we found so far that it's been very successful, that children feel good, or young adults feel good about now being buddies to children who've had this, who are now going through caregiving.
There's been a lot of discussion about resources. I'd like to spend a few minutes of time, and take your time, and let's make sure that people know where to find these resources. I know some of it's happening in the chat box, but I want to make sure that when people leave here today, they think, I can go here, I can find this. Anna, would you like to start? Or
Sure. And I think it's about looking internationally, isn't it? Because there's some amazing stuff out there. So I think, I've learned a lot talking with the rest of the panel. So there's a lot more out there. I mean, I think from in the UK, the Motor Neurone Disease Association resources that have been developed really with input, huge amounts of input from Laura Willicks, amazing publications out there, looking locally at your young carers support groups, maybe the local hospice, your local Motor Neurone Disease Association support group. On the MNDA website, there's age-appropriate resources from the Interactive Buddies website to stories and workbooks. They're age-appropriate. For older ones, there's financial grants, and there's a website forum. There's a helpline specifically for young people called Young Connect on motor neurone disease. Most recently, there's an innovation via the Motor Neurone Disease Association in relation to providing counselling, which is available. It's in partnership by the MNDA and Barnardo's. There's also a pilot project in relation to memory boxes, which are more MND specific. Again, huge amount of work by Laura. So I think it's looking at what's available locally, nationally, and now I think internationally, definitely.
yes, I think the MND buddies and the memory box links at some point were put in the chat box.
Yeah.
How about Jody?
Yes, well, within the United States, I think many organizations are beginning programs to recognize and support children and families. So kudos to all of you. At Hope Loves Company, as I've said, we spend every single day with this specific focus. So we run 6 camps across the United States, and all of our programs are free of charge for our families. We have group sessions twice a month, which are situations where children, we had one just recently, can call in on Zoom, and we just talk about how our day is and how things are going. So we have group shares. We also have family shares. In addition to that, we have a scholarship right now. We're offering 3 scholarships to children whose lives have been affected by ALS and are furthering their education. We send Hugs of Hope care packages, and on average, we send out about 5 a week, which is just with a book that gently explains ALS, and a card, a toy, and a shirt, and just allowing these children to recognize that they're not alone. We let them know we're here for them. So within the United States, we're doing the best we can to provide these services. You can reach out to us at www.hopelovescompany.org, and we can be found on all social media platforms. And I am open to, and I know our executive director, Kara Haggerty, as well. We're open to talk to anyone who is interested in expanding the resources that they are providing for their children and families. So thank you.
So I'll bring up the rear. I am so thrilled that I was a clinical social worker for many, many years, and that's why I study this. I saw children in clinic. I went to do home visits and saw children deeply involved in care and having zero resources whatsoever. So this idea of bringing resources to not only the children and the families, but the professionals is really one of my crusades in life, if you will. So I've been incredibly fortunate to work with the ALS Association. So I've had several research grants that has allowed me to interview children and youth across the country about their experiences with ALS. And so when we talked earlier about the books that we have for children and youth, these are all real kids. These are their real stories. These are their absolute individual perspectives. And so when kids read these books, they're knowing that this is where we're putting that peer-to-peer together, right? So these are real kids and their real experiences. We have a book, a graphic novel for young kids. It's in English, but it's actually, I've worked with the Swiss Association. I don't know if anybody's on the call from the Swiss Association. They're fabulous. We've translated that to French and German. We have a middle-aged, I shouldn't say middle-aged, tween teen book that is really built like a choose your own adventure. What would you do? And we profile kids who have made different decisions about talking to people, reaching out for support, who they engaged with, so that helps these kind of tween-age children say, well, maybe I'll do what this person did, or maybe I'll do something different. And then the third book is really for older teens and young adults. I know Connie from the Netherlands is on this call. Her daughter, Manouk, was interviewed for that book and gave us some extraordinary insight into what it's like to be an older teen or a young adult when you're trying to start your own life, and yet you are caring for someone that you love so much. Maybe you want to get married or you want to have kids. So all of these books are informed by the research in their interviews. We do have also a book that is also informed by the research and interviews for families. So those of you who are on the chat asking about how do we start that conversation? What does it mean like? This book on ALS and families really targets that, how to help you think about framing these conversations and doing it in such a normal everyday life. And then the last book is really targeted for school professionals. Because youth spend so much of their days in school, this really helps the teachers, the social workers, the school personnel, the counselors, capture these kids and provide support for them in a way that, again, normalizes their experience, doesn't isolate them, doesn't separate them, but helps educate the school professionals to know, how can we support these kids? And then lastly, the Y Care program. I've mentioned it several times. So it's a youth training and education program. One of the biggest things I found is that children and youth have no training, despite the fact that they're doing a lot of care. So this is a multidisciplinary program. We have physical therapists, occupational therapists, respiratory therapists, neurologists, social work. Yes, our neurologists sit and have lunch with the kids. It's the best thing ever. It's pure entertainment. And they love it. And it's an opportunity for kids to work with kids and for all these professionals to learn about youth and train youth and support youth. And all of the books books, I just saw someone posted, all of the books are available on the ALS Association website. The YCare program, we have our own full website. It's all in collaboration. It was primarily developed with the Wisconsin chapter. I know some Wisconsin folks are on the call. On Wisconsin. So, you know, really that information on YCare, you can email me, you can email the ALS Association. We've tried to put everything out there as engaging. There's, you know, no cost associated. And we would love to, I know I saw some other chats, some people are looking to translate the books to different languages. Yes, 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 and yes. I think you should contact Kim McGinnis at the ALS Association and she'll work with you. But again, we've already translated in a couple languages. I've worked with the Netherlands Association. They're considering translating them. So yes, absolutely. Thank you all so, so much. I'm done.
Wow. Do you know,
I'm never really done, but you know, I'm
there is literally steam coming off the chat. It is so hot. There are more than over 100 messages there, and I cannot keep up with it. But if you can put your information there, I think the conversation will carry on for a while.
I think Melinda highlighted something really important about resources for schools and teachers.
Yes.
Because I think it's about educating the people in schools because we're still talking a relatively rare condition. So there's an ignorance. So people perhaps aren't really aware of what's happening and what potentially will happen. And, you know, supporting the children, writing the letters for the exam boards. So hopefully it gives them, you know, a better understanding. It's all of that. So I think that's really important, also involving schools, obviously with the consent of the individual.
Yeah, I'll add to that very quickly that our ambassadors are writing a letter to their teachers. So once that letter has been edited and ready to go, we will share that. But our ambassadors, you know, have continuously said that their teachers and counselors and coaches may not understand what's really taking place at home. So they're penning a letter to best explain it.
That's fantastic, Jody. That's actually one of the places that was at your conference last year where the one woman mentioned that she just didn't know how to say to anyone at school, didn't know how to explain to her teachers.
Yeah. And right from the words from the mouths of the children. So
right. So so that would be something that would it be like a template then?
Yeah.
Is that what you're working on? That's fabulous. Yeah.
That's amazing. That's amazing. Sarah, did you have anything else to add?
Well, I had written down a question about the school, so I'm very glad that that was brought up. And then there are some questions. I've been monitoring the chat as well. Are we ready? Are we open for questions now, Rachel?
Yeah, no, definitely. Yeah.
So there are some questions about support groups for, like we discussed the written resources or the online resources. How about support groups for these young caregivers?
As I mentioned, Hope Loves Company runs 2 a month. We run them on Wednesday and Thursday evenings. Everything is on our website, hopelovescompany.org. They are open because of Zoom and because of the current situation, they are open to anyone. And we always have a counselor as well as one of our HLC staff members on the call. They're typically 7 to 8 p.m. Eastern Standard Time. And it's been, you know, we've had up to 10 children on the call, and it's just been an amazing opportunity to really connect on a different level with the children we serve, because they are at home and in their own environment, and they, you know, they're with their peers, and sometimes you learn more just from listening than anything else.
I will say many years ago, I learned the hard way many years ago when I was a social worker. I learned the hard way that often putting kids in a little circle and saying, okay, now everybody talk about your feelings and emotions. I always love to tell people that was my baby social worker, like huge, big mistake, lots of learning there. So what has worked out when we can get more face-to-face is having support groups in the context of activity, in the context of doing something that they are enjoying. You know, we used to take our groups on putt-putt golfing outings or bowling or, you know, even going to the mall. And in the context of these normal activities, you can have conversations about, so how are things going? So they aren't feeling on the spot, and they aren't feeling like I have to suddenly emote, and that can be very uncomfortable for children. So framing the support group in the context of a normal, fun, typical activity can be incredibly helpful to get them to talk about their feelings. I see Anna's head nodding.
Yeah, I think that's exactly what happened when we got the children together, when we were doing fun things, and they were exchanging mobile numbers, and you know, and they were making those support and witnessing conversations, you know, with someone who'd come along who'd lost a very close family member, talking to someone else quite openly about it, and this sort of like, oh well, I'm really sorry, and then they carried on. They didn't burst into tears. They talked, and because they got it, they looked, they understood.
Mm-hmm.
I just want to echo that those comments that we've been having since March. We've been having these group shares, and we had a young boy, 10 years old, whose father is living with ALS, and he's been joining, but both his sound and picture were off. And the last session we played video games, and in the chat he wrote, "I'm ready to do a voice and picture reveal." So that brought him in a way that he was most comfortable. So it's very important to have activities that will be the focus for that interaction and engagement and possibly conversation.
Yep.
And I think when we did our activities, we went to, when we had sort of single children in a family, we weren't too precious about if they wanted to bring their best friend along or whatever, because they felt it meant that they came.
Mm-hmm.
And I think that was really
great
important.
idea.
Yeah, made it safer, and then it meant that they were involved rather than not coming because they didn't know anyone and they didn't want to be part of it.
Mm-hmm. Mm-hmm.
We've done the same thing at Camp HLC. We've allowed children to bring their best friend.
Yeah.
Yeah. While Jody just mentioned that, let me just put a little plug in for that virtual camp. I had the opportunity to attend a weekend-long Hope Loves Company virtual camp, and wasn't sure exactly what I was getting myself into, but she did an amazing job of making this experience feel like a camp experience with s'mores and a campfire and sing-alongs and dance-alongs and everything, and the kids were broken out into the different age groups, and it was just amazing. So I would ask anyone to reach out to Jody for that, information.
Thank you, Sarah. You did a great job. You are just a natural when it comes to being with kids and being enthusiastic and fun. And the whole Hope Loves Company team and all the volunteers that joined us, and the children and the families, they're really what make the experience so phenomenal.
Brilliant. Sarah, is there anything else on the chat that you want to bring in?
So I just want to mention that there's been a lot of, again, to go back to the resources, because I know, again, when people leave, that's what they're going to want. And the International Alliance has, it is in writing here, is making a commitment to putting resources in a library of sorts on our website. It is, certainly one of the things that we're actually looking at is addressing the website itself. So these resources will be available. other than that, I haven't seen any new questions, but we do have some time here. I would like to give the panel an opportunity to, if there was something that they wanted to say, missed saying, or they caught a question in the chat, because it's a little difficult sometimes to see all the questions. If they caught something that they want to respond to, this is then the time to do it, please.
I would like to say one thing, and this is a response to, there was a couple, I've lost them now because, as you said, there's a lot of chats. So it was in there somewhere. People were making comments about, should youth be involved in care? Is this appropriate? And I just wanted to kind of circle back to that, because as a social worker, you know, I spent a lot of time as a practicing social worker thinking about this and thinking about it in terms of, you know, being a mandated reporter, and what is abuse and what is neglect, and how is that kind of seen in the context of being a caregiver as a child. And while I don't have, you know, kind of the all-knowing final answer, I think it is critical for us to think about it in the context of families as a whole. So in the absence of true abuse and neglect, being a young caregiver, being a caregiving youth in and of itself is not abusive. And I think it's important for us to think about it, kind of take a step back and look at, as we talked about earlier, what are the positives that children get out of this? And what positives do families get out of it by working as a family to help and support each other? But at the same time, as professionals, being very, very aware of asking about, are there youth in the home providing care? What are they doing? How can we support you? So when we see that it crosses that line into maybe some negative, it's typically because there's no supports for that family, and they're relying on what they have on hand. So I guess what I'm trying to say is, it needs to be a collaborative effort, not immediately saying it's a negative and, you know, we need to remove the child from the home or remove this situation. What supports does the family need as a whole? How can we support everybody? And then how can we look at the positives and the strengths that come out of not only the youth, but the family as a whole? And that's where I think these resources, the camps, you know, the support and training programs, the online programs, I really encourage everybody to engage them as much as possible, because that's where we can move away from the conversation about, oh, it's bad and we need to just remove the kids. So I just wanted to bring that up. It was somewhere in the chat earlier, and I get that a lot when I present at research conferences. Every single time I get at least one person coming up to me and chastising me for even doing this research. And so I just think it's, oh yeah, it happens all the time. And that, you know, and it's okay. It's about educating people. It's about educating everybody that we have to do better for these kids and their families. So that's all I'll say about that.
And it starts off with that initial question, isn't it? Are the children? If we don't know, how can we know?
Mm-hmm. Completely.
Are there children, and how are they doing?
Yeah.
Mm-hmm. Yes.
How are they doing?
Mm-hmm. Mm-hmm. Absolutely. And, you know, in the US, I know there's a lot of folks from around the world on the call, but in the US, I will say pointedly, we do a terrible job of even asking about kids and families, much less children and youth being caregivers, regardless of the disease state. They are left out of all state and national programming. They all begin at the age of 18. We have nothing at a national or a federal level for anyone under the age of 18. So these are kids who don't enter into the conversation. So of course, our knee-jerk reaction is it's a bad thing. But I hope that this is one thing we can kind of collaborate internationally on or really get the ball rolling here in the US, that this is not intrinsically in and of itself a bad thing, and that we can, as professionals, can do better.
Brilliant. Thank you. Thank you so much. Jodie, did you have anything to add to that?
Now, one of the things I'd like to add, it's a little off topic, but I find that it's extremely helpful when I do share it. And this is a personal story. So as I have said several times, I've raised 3 children. But for those of you who don't know my story, I lost my husband to ALS. And we had 1 child together. And the man that I remarried, Warren Benton Ames, lost his wife to ALS. And he and Tina had 2 children, Nora and Adam. So having 3 children with this experience has taught me many, many things. And the first thing that it really taught me was the relevance of communication, memories, resources. I mean, so many things. But the one thing that Alina and Kevin and I did was to create a lot of cards and memories, written word, written some tapes and experiences. And Tina and my husband Warren did not do that. And so I have found that it's important for me to remind families. One of the things that Kevin and I did when he was at late stage is I read his lips when he was vented, and we together penned 10 cards for every milestone for Alina. And we have 1 left, which is her wedding day card. And it's his thoughts and my writing, and it's on a card, a wedding card. And to have that in the other room, she's now engaged, and to have that for her just means the world to me and to her, and I can assume Kevin too. So I just think it's important to, I know it's a very frightening thing to think about, but I know that every time my grown children come home, they go right to their photo albums and right to the memories that they've had. It's a comfort thing when they're here. And so I just wanted to share that it's been a gift to us, and it may be a gift to your family as well.
Jodie, thank you so much. I think that's the most powerful note that I think we could possibly finish on right now. But I think I think we've probably exhausted all the questions in the question box. There's only one little one just at the bottom there now that I haven't. So I cannot thank you enough, all of you, for your absolute dedication and entertainment and knowledge and wisdom. Thank you so much to Jodie, Anna, and Melinda on your presentation. Thank you.
Yes. Thank you so much.
Thank you for having us.
Absolutely.
Oh, yes, absolutely. Absolutely. And thanks to everybody on the chat. You guys are on fire. I'm like, woo! It's amazing.
Brilliant.
Keep up the good work, everyone.
Yeah. Woo!
Thank you.
Fantastic. So I'd kind of like to start to thank everybody for coming to the Allied Health Professional Forum in 2020. I have to say it is quite a highlight of my year. I think if Sarah can come up too, then she can finish off with me if there's a picture of her too. But I think I think I always wait for this opportunity once a year to really recharge my batteries, to learn and to kind of go again for the rest of the next year on the energy that I get from these forums. And I will certainly do that from now. Sarah, are you there?
Yes, I'm here. I'm in the background.
I think on behalf of kind of Sarah and myself, I think we would very much like to thank everybody who's been involved with putting this this panel together and the whole of the program, and Kathy Cummins particularly, And Sarah, have you got anything else to add before we just move on to the last speaker?
There's no speaker.
Yes, we're going to hand back over to Calanet
Calanet, yes, no.
Yeah.
No, I agree with you. This is something that I look forward to every year as a way to come together with everyone else who is doing the same or similar work, whether they're brand new or experienced. We can talk to each other and network, and as you said, recharge our batteries so that we can, going forward, we might again have something that, okay, we know that what we're doing is we're going the right path, or maybe there's something new that we can take away right away, or maybe there's something that we can aspire to do, like I mentioned earlier. So that's really, what we have, what I look forward to from this. I think this year, putting it together in our virtual format, there are some things that absolutely worked brilliantly, to use Rachel's word. And I think we should consider keeping certain pieces of it. And then there are things that you might not know from behind the scenes did not quite go as swimmingly as we had hoped. But certainly I look forward to seeing people in person if we can in the future. And if not, certainly doing more of these kind of virtual events.
Yes, thank you. And it's been a pleasure to moderate with Sarah, and a real honor to have been asked. So thank you for that too.
Yes, welcome.
So I think enough from us. May I hand over now to Calanet to have some final...
Yeah, they're tired of seeing us from the last.
Watch it, Sarah will start dancing and then there's no hope. So may I hand over, and thank you very much.
Well, that was just a great way to finish this week. I am so energized and so excited, and I completely agree. There's such value in some of this virtual interaction, even just being able to chat and have kind of real-time background conversation going on. So that brings me to a couple of things. We will be sending out a certificate of attendance to everyone. And we're also going to be sending out a survey. And please, 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 please fill out that survey. Should we ever have to do it completely like this again, hopefully next year we'll be together in some form or fashion in person. But even some of the comments that I'm seeing come through the chat right now, if you could put that into the survey. Second, I just want to thank everyone. It's just been amazing. Our members, the patient fellows that have joined us, you've made the conversation so enriching. Our sponsors, everybody that's a part of this community. It's just been really amazing to see the energy keep going day after day, even in this virtual space. So thank you for that. There is going to be the chat that will be open. The networking session will still be open for another 30 minutes. So you're more than welcome to stay and continue the conversation or the conversations with each other. And just from the bottom of my heart, I thank all of you for all that you do. I did write into the chat, and so did Kathy. As you might have seen in the Alliance presentations, we have made a commitment to revamping and updating the website. Phil Green has been leading our PCAC with that effort, and we're really excited to pull those resources. It's been part of our strategic plan that we put together a couple of years ago. So please send those resources. I do want to work with you, Marcella, on translation and many others. And so that's why we're here as an international community. So we don't have to duplicate efforts. We can leverage opportunities from each other. We can learn from each other. And I'm just excited to be a part of that. So thank you for attending, and maybe we'll see you next week at some of the research meetings. If not, I really hope that we get to interact and see each other soon again. Have a great rest of your day and your night. Bye.
Kalaneet, can
well
you?
Done, Kalaneet.
Can you introduce the video?
Oh, yes. I'm sorry, I didn't know there was a video. Here's a video for you to see.
Welcome to Switzerland.
Oh, it's playing again. Yeah. Oh, right. Yes. So if you haven't, sorry about that, Kathy. You know, I've been on this video for 7 days straight. If you haven't seen yet, like I said, we hope to be together in person next year. We hope to be in Basel, and here's a beautiful video, which I know made me want to go even more, and I'm hoping it'll make you want to attend too. So please watch.
Ich spüre die Magie von der Schweiz in jeder Pore von meinem Dasein. Fällt der erste Schnee, habe ich das kribbelnde Gefühl in mir. Die Berge sind Energiequelle und Kraftort. Die unberührte Natur führt mich zu mir, lässt mich tief atmen. Die Schweiz ist das Wasserschloss von Europa. Für mich widerspiegelt das Wasser den reissenden Fluss vom Leben. Unsere Kultur lässt mein Herz tanzen und oft bringt sie mich zum Staunen. Explosion von allen Sinnen. Tick-Tack, Tick-Tack. Hier pulsiert das Leben. Die Schweizer Pünktlichkeit ist kein Mythos. Auch, dass es hier sehr sauber und sicher ist wahr. Was wünschst du dir? Ruhe, Abenteuer, Kultur, Freiheit. Das kannst du alles haben. Folg deinem Herzschlag. Folg dem, was dich glücklich macht. Wir haben eine Chance zu leben und die gilt es zu nutzen. Für mich und die rund 700 ALS-Betroffenen in der Schweiz ist es eine grosse Ehre, dich im Dezember 2021 zu Basel zu begrüßen.
Der internationale ALS-Kongress 2021 bietet die Möglichkeit zum Austausch zwischen Forschenden, Klinikern und Betroffenen. Reisen Sie 2021 zu uns in die schöne Schweiz, ins Herz von Europa. Es lohnt sich. Herzlich willkommen.
Thank you again. Doesn't that look just beautiful? Oh, I just want to be there right now. Thank you to everyone, and a big thank you to our amazing behind the scenes tech team. They have been doing just a great job. I disagree. I think everything went perfectly seamless and smooth. Just joking. Of course, we had a few glitches. We knew we would, but thank you so much for making this happen. This is certainly not in my wheelhouse. I wouldn't know how to pull this together, this technology. So thank you so much. I hope everyone enjoys the rest of your day and night and the rest of your year. Happy New Year if we don't talk before.